to find the innovative ways to combat this crisis. I also appreciate the fact that the administration included Hyde Amendment pro-life protections in all proposed funding language. It is important to ensure that federal funds are not used to perform abortions, and I hope that as this subcommittee moves forward with reauthorizations and the Appropriations Committee puts together the bills for fiscal year 2021, they will maintain those protections. Other important programs and policies receiving increased funding, including the Maternal Child Health Block Grant, the Health Resources and Services Administration's Maternal Health in America initiative, and the 340B drug pricing program. Funding increases for the Centers for Disease Control and Prevention's influenza program is particularly important as we now face this worldwide coronavirus outbreak. Which brings me to the novel coronavirus, and it has infected over 80,000 individuals worldwide, proven to be more deadly than SARS. I appreciate the Trump administration's vigilance and rapid response efforts. Mr. Secretary, let me just say, I was so heartened, I think it was 4 Fridays ago when you came on the air and said there was a limit to people being able to come into this country from China, and I thought that was important that the administration say that, and I believe that is one of the central things, my thesis is, that is one of the central things that has provided us at least a little breathing room as this virus erupts around the world. We're fortunately not as affected as some other countries. Now it's incumbent upon us to make sure we utilize that time wisely. Certainly the Pandemic All-Hazard Preparedness Act, which was worked on by this subcommittee in the last Congress and finally passed at the beginning of this Congress, important piece of legislation. I would have liked for us to have done real-time hearings, updating. Are we doing what was intended with that bill? Is the stockpile responding appropriately to the authorizations that we made? And this is the type of information, rather than the political rhetoric back and forth that we've heard, this is the type of information that I think would be helpful and indeed reassuring to the American people. You can't ignore the fact of what's happened to the markets. Today we're grateful that they seem to have rebounded a little bit. But look, we all know China has not been forthcoming with information, and it is that uncertainty that I believe is driving one of the negative forces driving the market. Mr. Secretary, I appreciate you being here today. We'll have multiple questions for you. I certainly look forward to your testimony. Thank you. I yield back.
The gentleman yields back. I want the ranking member to know the following. On January 30th, I requested that the following week that we have a hearing on the coronavirus with the heads of the agencies. The Secretary leaned in and said, I head up the effort and I want to be there with that team. And here we are today. So this is not something, Dr. Burgess, that we just casually overlooked or ignored. That is far from the fact. I now would like to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes.
Thank you, Chairwoman Eshoo. Today's hearing serves 2 critical purposes. First, we will examine the Trump administration's proposed budget for the Department of Health and Human Services for fiscal year 2021. And second, we'll get a crucial update on the administration's ongoing response to the coronavirus. I am disappointed, though not surprised, that the Trump administration budget proposal completely contradicts the health care promises that the president repeatedly makes to the American people. When it comes to ensuring the American people have access to affordable and quality health care, the Trump administration has failed them, and this budget proposal continues that record. 2 years after showering the wealthy and large corporations with major tax breaks, the president's 2021 budget proposal slashes $100 billion from the Affordable Care Act, $500 billion from Medicare, and more than $900 billion from Medicaid over the course of 10 years. And the president also wants to make it easier for states to take away people's coverage, undermine their care, and cut critical benefits. And this puts the health and well-being of tens of millions of children, parents, pregnant women, and people with disabilities at risk. Medicaid is a lifeline for millions of working-class families, and it's unconscionable that the president wants to cut it to pay for tax cuts for millionaires. Now, these budget cuts also fly in the face of President Trump's own words. He promised that as president, he would not cut Medicare or Medicaid. And he promised in a State of the Union address earlier this year that he would continue to protect the more than 130 million Americans with pre-existing conditions. But as Secretary Azar knows, this administration is now suing in the federal courts to strike down the ACA and all of its consumer protections. Overall, President Trump is proposing a 12% cut to the HHS's budget, one of the largest cuts to any federal agency. The devastating cuts don't end at Medicare, Medicaid, and the ACA. The President's proposal cuts the National Institutes of Health by $3 billion and the Centers for Disease Control and Prevention by $675 million. And keep in mind that this is the very agency that is now responding to the coronavirus. And I'm also concerned by the proposal to move tobacco regulation out of the FDA's authority altogether. Instead, the administration would create a new untested agency to oversee tobacco products while we're in the midst of a youth tobacco epidemic. After years of regulatory uncertainty, the Tobacco Control Act clearly and unambiguously ensured that FDA would regulate tobacco products for the protection of public health. But over the last decade, the agency has worked to develop the expertise, workforce, and scientific basis to effectively regulate these products. So I'm concerned that this proposal would only serve to further politicize tobacco regulation by stripping away FDA's sound scientific and evidence-based approach and replacing it at the whims of political appointees, and it's nothing more than a gift, frankly, to big tobacco companies. Now, let me just move to the second topic at hand. After we discuss the budget, we'll ask questions of the Secretary and other top public health officials on the administration's efforts to address the coronavirus outbreak. It's critical that we get an update on the scale of the outbreak, its repercussions in the U.S., and how we can work together to ensure the safety of all Americans. I think we have one of the strongest public health infrastructures in the world, and it's more than capable of coming to an effective solution. And we should be supporting that system with all available resources. So again, Madam Chair, I thank you, and I think, well, I actually have time left if anybody wants it, but everybody gets time, or does anybody want my time? I guess not. All right. Thanks a lot. I yield back.
The gentleman yields back. Pleasure to recognize the ranking member of the full committee, Mr. Walden, for his 5 minutes for his opening statement.
Thank you, Madam Chair. Good afternoon. And Mr. Secretary, thank you for being here today. It's not the first time we've seen you, although here I think this year probably, but certainly we appreciate the work you and your team have done dealing with the coronavirus. I think I've been in every one of the roundtables and hearings that you and your team have provided for this committee and other committees. Chairman Pallone and I were the co-moderators of the first one in the Visitor Center, where every member of Congress was invited. And I was at the last one, and I was at the Situation Room at the White House before the break. And this, you know, I think you all have been very forthcoming with the facts. And for whatever reason, we haven't had a hearing here, maybe wanted to wait till this one, but I think it is important that we hear from you and the team that you're leading. And I think it's important to recognize the work that Mrs. Brooks did on reauthorizing the Pandemic All-Hazard Preparedness Act in the last Congress. We had big fights about that, but thank goodness it's in place because it's designed to do exactly what we're encountering today. Have a lead person in the administration, that is you, designated by the President, and a team ready to go. And so I guess I've been to enough of those briefings that I saw members kind of yawning at some point in those quote-unquote closed-door briefings because we're hearing it for the third time. Now, we were gone a week, and a lot's changed, and we know what's happening in China is probably worse than we're being told, and I think the big issues there are supply chain as well as public health. We know it is spreading around the world, and we're trying to cope, and we know, and you've warned us, and Dr. Fauci's warned us and others expect it to, you know, this could well mutate, but that doesn't mean end of world. It can well expand. We should be ready for that. But as Mr. Pallone said, we have a terrific public health system here in the United States. A lot of that is driven at the local level, and it's important we have those communication links in place so that when we identify somebody coming in through an airport, the local health officials know about it at home, and we're able to deal with it. And I think it is good to get this out in the public. I would just point out that we will hear from you and the CDC, FDA, and ASPR and NIAID to give us an update on the sidecar hearing. We have had now, 80,000 confirmed cases worldwide, 2,700 deaths. The outbreak's become a significant global health concern. Yesterday, Italy announced 300 individuals have been affected by the coronavirus. 11 had died. There's still much we do not know about the outbreak. And so we'll learn more, I guess, after this budget hearing. But it is essential that we do everything we can and provide you the assistance. And I know in the meetings I've been in with everybody else on this committee that was there to attend, you've made it clear if you need more money, you'll ask us, and we've made it clear if you need more money, tell us, and we'll work with you. Now, we'll want to get the specifics, obviously, but I know you've sent up a supplemental request for, I think, a total of about a little over $2 billion, $2.5 billion. Some of that's reprogramming, some of it's additional money. No sooner had that left your office than some politicians were on the air criticizing you for not asking for enough. And so we'll be interested to get your response to that. I do think it's also essential to look at perspectives in terms of what Americans are facing today with the traditional flu, and that we've probably lost, 10,000 or more Americans have died from the annual flu. And we have vaccines for that and treatments for that. And so we have to think about that as well and practice good public health. I was in Japan with a couple other of my colleagues on the committee, and you can't go anywhere in Japan without the hand sanitizer being squirted in your hands. And it was a good lesson, I think, for all of us, but we ought to be doing a little bit more of that here, and we'd probably help with the traditional seasonal flu and spread of other diseases. And so there's a lot we can learn from you, there's a lot we can learn from your team, and we'll look forward to hearing from you directly on that, on the record here in the public. So with that, Madam Chair, I yield back.
The gentleman yields back. I now would like to introduce our witness for today's first panel. One person alone, the nation's Secretary of Health and Human Services. Welcome to you, Secretary Azar. You certainly are familiar with the lighting system around here, so you are now recognized for 5 minutes for your statement to the committee. Thank you for being here.
Thank you very much, Chairwoman Eshoo, Chairman Pallone, Ranking Members Walden and Burgess. Thank you for inviting me to discuss the President's budget for fiscal year 2021. I'm honored to appear before the committee for budget testimony as the HHS Secretary for the second time, especially after the remarkable year of results that the HHS team has produced. With support from this committee, this past year we saw the number of drug overdose deaths decline for the first time in decades, another record year of generic drug approvals from FDA, and historic drops in Medicare Advantage, Medicare Part D, and Affordable Care Act exchange premiums. The President's budget aims to move toward a future where HHS's programs work better for the people we serve, where our human services programs put people at the center, and where America's healthcare system is affordable, personalized, puts patients in control, and treats them like a human being and not like a number. HHS has the largest discretionary budget of any non-defense department, which means that difficult decisions must be made to put discretionary spending on a sustainable path. The President's budget proposes to protect what works in our healthcare system and make it better. I'll mention 2 ways that we do that. First, facilitating patient-centered markets, and second, tackling key impactable health challenges. The budget's healthcare reforms aim to put the patient at the center. It would, for instance, eliminate cost-sharing for colonoscopies, a life-saving preventive service. We would reduce patients' costs and promote competition by paying the same for certain services regardless of setting. The budget endorses bipartisan, bicameral drug pricing legislation. And I want to thank this committee for your bipartisan work to pass legislation such as the CREATES Act to cut patient costs and save taxpayer dollars through lower drug prices. The budget's reforms will improve Medicare and extend the life of the Hospital Insurance Fund for at least 25 years. We propose investing $116 million in HHS's initiatives to reduce maternal mortality and morbidity, and we propose reforms to tackle America's rural healthcare crisis, including telehealth expansions and new flexibility for rural hospitals. The budget increases investments to combat the opioid epidemic, including SAMHSA's State Opioid Response Program. This successful grant program grew out of this committee's creation of the state targeted response grants in the Cures Act, and we were pleased to work with Congress to provide flexibility on the SOR grants for states to address stimulants like methamphetamines. We request $716 million for the President's initiative to end the HIV epidemic in America by using effective evidence-based tools. Thanks to support from Congress, we've already begun implementation of the initiative. The budget reflects how seriously we take the threat of other infectious diseases, such as the novel coronavirus, by prioritizing the funding for CDC's infectious disease programs and maintaining investments in hospital preparedness. As of this morning, we still had only 14 cases of the novel coronavirus detected in the United States involving travel to or close contacts with travelers. Coming into this hearing, I was informed that we have a 15th confirmed case, the epidemiology of which we are still discerning. 3 cases also exist among Americans repatriated from Wuhan, and 42 cases exist among American passengers repatriated from the Diamond Princess cruise ship in Japan. While the immediate risk to the American public remains low, there is now community transmission in a number of countries, including outside of Asia, which is deeply concerning. We're working closely with state, local, and private sector partners to prepare for mitigating the virus's potential spread in the United States, as we expect to see more cases here. On Monday, OMB sent a request to make at least $2.5 billion in funding available for preparedness and response, including for therapeutics, vaccines, personal protective equipment, state and local public health department support, and surveillance. I look forward to working closely with Congress on that proposal. This year's budget aims to protect and enhance Americans' well-being and deliver Americans a more affordable, personalized healthcare system that works better rather than just spends more. I look forward to working with this committee to make that common sense goal a reality. Thank you very much.
Thank you, Mr. Secretary. And we'll now move to member questions, and I will recognize myself for 4 minutes, which will be the limit for questions to the Secretary. Mr. Secretary, we know that on February 24th, the acting director of OMB, what was requested, the appropriation of $1.25 billion for emergency funding for the virus. Is that what you requested of OMB?
So the actual total supplemental authorization would be $2.5 billion. We proposed
know,
half of that to be covered.
The new funding is $1.25.
I do want to emphasize, as I've told the appropriators, that was meant as a suggestion of a way to fund half of it, but if Congress decides there are other approaches, we're not wed to that.
What exactly does that cover? And is it anticipatory? Now, yesterday, the CDC said we need to be prepared. Essentially, we need to be prepared for a much larger spread of this virus in the United States. So is what has been requested in emergency funding to cover a broader plan, or is it on the figures that you just gave us?
So it is to cover expenses that we believe are appropriate for 2020. So this would go through the end of 2020 fiscal year, and then we would work with appropriators on any adjustments to 2021 appropriations in the weeks and months ahead as we continue to learn on a daily basis about the spread of the disease. Core investments. First, surveillance, expanding our surveillance system for novel.
I have some other questions.
Oh, sure.
So,
Okay.
and,
But I'm happy to walk you through the 5 key critical success
I read
areas.
the entirety of your printed statement. I want to turn to the status of drug pricing policy proposals. If you could just say yes or no, it would be great. Have you finalized a policy ending drug rebates to middlemen in Medicare?
We did not move final with that rule.
Okay. Have you finalized a policy tying drug prices to the lower costs as the reference pricing?
We had an advance notice of proposed rulemaking, so that was not an actual formal proposal yet.
Have you finalized a proposal to make drug manufacturers put list prices in television advertisements?
We did, and much to their shame, the pharma industry sued, and Congress has not passed explicit authorization for that list price requirement in the statute that I
Are you
wish they would
planning to
do.
finalize or pursue any of these policies in the near future?
We plan to finalize as soon as we can the importation program implementing Section 804 of the Food, Drug, and Cosmetic Act to allow low-cost importation from Canada.
You know that the House passed H.R. 3. You also know that the president said that we're going to negotiate so hard, something like that. We're going to negotiate like crazy. Do you support direct negotiations?
We do not support H.R. 3 because we don't believe the negotiation framework in there is either a negotiation or actually practical and implementable. And it also just has no chance of passing in the Senate. The bipartisan package of Grassley-Wyden is struggling even to get to the floor there.
Well, H.R. 3 caps out of pocket, as you know, prescription costs for seniors. Do you support the capping of out-of-pocket costs for them?
We have an important opportunity here,
Yes or no?
bipartisan,
Yes
to
or
cap
no?
out-of-pocket spending and reduce what seniors
Yes or
will pay in
no?
Part D. So yes, we do.
Okay, good. Well, I think that I've asked all, let me just, well, H.R. 3 also limits drug price hikes to inflation. Do you support the inflation caps?
So that is part of the Grassley-Wyden package also in the Senate. And
You support it?
we've made clear that that's a package we can support. It's not the only bipartisan package, but the price inflation penalties in Part D and B are acceptable to us as a means of getting list prices under control.
Thank you. My time has expired. I now would like to recognize the ranking member of the subcommittee for his 4 minutes of questions.
Thank you. Mr. Secretary, in December of 2018, the President signed 2 important bills into law that addressed maternal health and maternal mortality. The first bill, Representative Jamie Herrera Butler's Preventing Maternal Deaths Act, established a grant program for states to establish or expand maternal mortality review committees. The other bill, Improving Access to Maternity Care Act, required health resources, HRSA, to identify maternity care health professional target areas. So how have you used these bills? How is your agency building on the success of those 2 laws to ensure access to quality maternity care and prevent maternal mortality?
First, could I thank you for your leadership on immunosuppressive drugs? I hope you saw that we put in the budget what you've long advocated for in terms of that coverage.
Yes, you may say thank you. You're welcome.
And on maternal mortality, also, the work of Congress really focusing on this critical issue. Too many women are dying either in childbirth, preterm, at childbirth, or postpartum. And so we have made this a serious part of the President's agenda with a $116 million initiative with the $74 million increase that focused on improving prevention, quality improvement, postpartum health, and improving the data collection on that. So a 4-part strategy that we look forward to working with Congress on coming out of the budget.
Well, thank you for that. Republicans in this subcommittee in 2017 sent your predecessor, Secretary Price, a letter asking for HHS to update and release the pandemic flu influenza plan, and previously had not been updated since 2005. Can you describe how you are using the pandemic influenza plan as a guide in preparing for your response to this current outbreak of coronavirus?
So as you know, I was one of the architects of the original pandemic plans back in the Bush administration. That work is foundational. That's what has set up our entire state, local, and federal preparedness program for any type of viral outbreak like this. And so it's really it is the blueprint for how we are operating today, including my role leading through the Emergency Support Function 8 under the National Response Plan, which is the doctrine that we've had in place now for 15 years.
Let me just say, this committee did do work on H.R. 3 last October. There was concern from many of us that the negative effects on innovation and development would really be profound. And now we find ourselves confronted with this coronavirus outbreak where we know we need new antivirals. We know we need new vaccines. We know we need new monoclonal antibodies to help people who become ill. Can you just speak to the fact of, is innovation still important? Because we heard several times in this subcommittee and in the full committee that maybe innovation wasn't so important as getting cheaper drugs into people's hands.
Innovation is vitally important, and that's why two of the key legs of the supplemental request are to develop vaccines and therapeutics for this novel virus. One of the challenges with H.R. 3 is the sheer amount of money it would pull out of the system. And I'm not a believer that if you pull any money out of the drug industry, it's catastrophic or impossible. But the sheer amount would materially impact the bringing forward of drug therapies for Alzheimer's, for arthritis. Just go through the list of therapies that you need to incent or you won't get them.
Yeah, and interestingly enough, the Alzheimer's drug that was withdrawn a year ago, I'm reading is now getting a new look at different dosing schedules. And again, work like that, that's not going to happen if we don't value innovation. But Secretary, I thank you for being here and certainly look forward to the second part of this hearing. I yield back.
The BARDA biodefense budget has also been cut. Now, glad to recognize the chairman of the full committee for his 4 minutes of questions.
Thank you, Chairwoman Eshoo. Mrs. Secretary, I thank you for appearing before our subcommittee today, but I continue to be upset by the Trump administration's decision to ask the court to strike down the ACA in the Republican lawsuit that is seeking to declare the entire law invalid. If the district court ruling is upheld, then the Trump administration will be responsible for the largest coverage loss in U.S. history. Over 20 million Americans would lose their coverage, raising consumer costs and making life-saving health care unaffordable for American families, and it would eliminate protection for pre-existing conditions, adversely impact the Medicare program, and end Medicaid expansion. So I've sent you 3 letters now, including one in April of last year, requesting any analysis, study, assessment, or reports regarding the potential impact if the entire ACA is found to be unconstitutional. And for almost 2 years now, I've repeatedly asked for any documents relating to any contingency plans in place in the event the ACA is found unconstitutional. Only last week, I received a 1 and 1.5 page response that answers none of my questions, frankly, and the documents produced so far to the committee answer none of these questions. So I'd like to submit to Madam Chair my letters and the department's response in the record. I'd ask unanimous consent.
So ordered.
So really, I've got 2.5 minutes here, Mr. Secretary. I think the American people have the right to know what the administration's contingency plans are, given the president asking that this entire law be declared invalid. Maybe you just have to answer yes or no. We'll see. I only got 2 minutes. Secretary, has the department conducted an analysis to evaluate the impact on individuals with pre-existing conditions and their access to affordable health insurance if the ACA is found unconstitutional? Yes or no?
Of course, it's not going to be left just like that. We would replace with something that would actually deal with pre-existing conditions. And
but have you done any kind of contingency plans that what would happen if the court struck down the ACA?
We're always considering different options, but it will depend on the nature of any ultimate court decision, if it even agrees with striking down all or part of the ACA.
Well, it doesn't sound like there is such a thing. Has the department conducted an analysis to evaluate the impact on premiums and access to coverage in the individual market, particularly for individuals with pre-existing conditions, if the ACA is found unconstitutional? Yes or no?
Well, it depends on what would be struck down. Or all of it struck down, part of it, or none of it. Okay. We are years possibly away from a final court decision.
All right, well, let me ask you this. Are there any contingency plans to ensure that the 20 million people who are covered under the ACA do not lose coverage? Anything at all?
Well, first, we have been emphatic that we are changing nothing about how we administer this program during the pendency of the litigation. And at the time that if there is a final court decision striking down all or part of it, it will depend on the context of that decision and the politics, frankly, of who's in Congress and what we can work with to ensure the protection of existing conditions.
It sounds like the answer is no, you don't have anything yet. I would just like a commitment from you, basically, to respond to my request, to provide any documents to the committee that relate to contingency plans in the event that the ACA is struck down. Can you give me that commitment?
I'm sure you'll understand that deliberative process regarding potential legislative proposals are some of the core of the internal executive department's functions.
So it sounds like the answer is no. Well, I just think that it's unfortunate because, you know, our oversight responsibility is to make sure that in the event we have this terrible situation, that there is some kind of contingency plan, and I don't think you have it. So I don't believe the administration has any kind of comprehensive plan to address the fallout that will occur if this if this Republican suit is successful in court. Thank you, Madam Chair.
The gentleman yields back. The chair recognizes the ranking member of the full committee, Mr. Walden, for his 4 minutes.
Thank you, Madam Chair. Mr. Secretary, again, thanks for being here. I want to make a couple of points. One is on the opening day of this Congress, I led the effort on the House floor, now in the minority, trying to move an effort to protect people with pre-existing conditions pending this lawsuit's decision. Congress could act. This House could move legislation to put into law certainty to protect people with pre-existing conditions, in addition to the laws that are already on the books dealing with pre-existing conditions. But my colleagues have chosen not to do that. So they could, and we would probably find common ground here on a pre-existing severability language. There's a lot that could be done here. Second, it was the Congressional Budget Office, independent, nonpartisan, that said, I believe 8 to 15 new medicines would never be invented because of H.R. 3, Speaker Pelosi's partisan drug pricing bill. As you said, that could be a cure for Alzheimer's. It could be a cure for the coronavirus. We don't know. And that's just in the first 10 years. The further out you look, the more future innovation would be lost. California Life Sciences said upwards of 85% of what they invest in would go away. 80,000 U.S. jobs, 80,000 is what California Life Sciences said. We'd lose the R&D, we'd lose the innovation. Now, no president, I've been around, Republican or Democrats, ever leaned in harder on these issues of cost of care than President Trump. And I was with you and him when he announced the effort to get transparency in the hospital system. And before we got from the news conference, the Oval Office, I believe the hospitals had sued you. Is that correct?
I believe it is.
Yeah. And on you talked about the drug disclosure and advertising. And what happened there?
Rather disgustingly, the pharmaceutical industry sued us to conceal their list prices from their consumers.
And so then I want to talk about Medicare Part D. We were all working together on this committee, which we have a great reputation of doing. Occasionally we fight, and that's all right, we know it. But we were working together to cap the out-of-pocket cost for seniors under Medicare Part D and modernize Medicare Part D. When all that, unfortunately, came to an abrupt halt, driven, I'm going to say, from the Speaker's office, those discussions ceased. But we agreed that we needed to cap out-of-pocket costs. We put that in our bill, H.R. 19. They put that in their partisan H.R. 3. But we all agree that it's time to cap the out-of-pocket costs for seniors in Medicare. Does the administration support capping the out-of-pocket costs for seniors in Medicare?
Absolutely.
Did the administration oppose H.R. 3?
We do oppose H.R. 3.
Did the administration support the concepts of H.R. 19, our alternative?
We support the elements of it, absolutely, including the notion of capping out-of-pockets and saving seniors money.
One of the big issues we've dealt with here, or tried to, is the high cost of insulin. Not just for seniors, but for others. But in our alternative, H.R. 19, that was all bipartisan legislation, we capped cost of insulin, I believe, at $50 a month was the maximum. Does the administration support that concept?
I believe so, yes.
So going forward, are you hopeful that the Congress and the administration can get together on a plan the president can sign that can become law that would actually reduce the costs of pharmaceutical drugs in America without driving innovation away?
Yes, I have said the administration is the most flexible party here. Republicans, Democrats, Senate, House, get list prices under control, lower out-of-pockets, and give the drug plans the real incentive to get drug prices down.
H.R. 19 contains about 80 or 90% of the Wyden-Grassley bill. We think we're with you. We think we can get there if we can just put the partisan weapons away. Thank you, Mr. Secretary, and I yield back.
Gentleman yields back. Pleasure to recognize the gentleman from New York, Mr. Engel, for his, is it 4 minutes? 4 minutes of questions.
Thank you, Madam Chair. Secretary Azar, the state of New York was extremely disappointed to hear that CMS has denied the state's request for a renewal of its Delivery System Reform Incentive Payment Program, known as DSRIP. When the program was first approved, CMS and HHS insisted that New York include targets for the state's Medicaid program that would incentivize providers to move away from fee-for-service toward value-based payments. New York's health care community has made progress in doing just that, receiving double-digit reductions in preventable hospital readmissions while saving the federal government billions of dollars. The request for additional time and continued investment of those savings in DSRIP was to move closer to exactly what CMS and HHS have been saying the federal government wants everyone to be doing. So in light of that, why would CMS and HHS want to stop supporting these successful efforts to achieve the very goals that the Trump administration has been saying that it has for health care? So will your department commit to meeting with the state of New York to discuss how these reforms are sustained into the future? I'd like a yes or no answer if I could get it.
Yes, I'm not familiar with that particular program, but you're right, we do support value-based transformation in our programs. I don't know the particulars of why CMS has had difficulty with New York, but yes, we'll be happy to sit with New York.
Okay, and I'd be happy to sit with you as well.
Thank you.
Discuss it. Mr. Secretary, we've mentioned it here, other members have mentioned it here, and you know it far too well, that Americans are suffering from the current epidemic of skyrocketing prescription drug prices. My constituents always tell me they're having to make unconscionable choices between paying for food or filling a life-saving prescription such as insulin. The House has taken bold, decisive action to lower drug prices through H.R. 3, which provides a common-sense solution to this crisis by allowing the government to negotiate drug prices. That's a policy that the President supported as a candidate in 2016, saying, and I quote, "When it comes to negotiate the costs of drugs, we are going to negotiate like crazy," unquote. That's from the President. The administration has yet to deliver any meaningful solutions for the health crisis. In May 2018, your department released a blueprint to lower drug prices, but many of those policies failed to materialize or provide minimal relief to patients. Other ideas, such as the International Pricing Index, has been shelved. Despite these failures, President Trump claims to have reduced drug prices, when in fact a recent report showed that on average, drug prices increased by over 5% at the start of this year. Mr. Secretary, can you commit to me today that you will deliver on the President's promise to negotiate drug prices? I'd like a yes or no also.
So we support bicameral, bipartisan legislation that would get through, and there are many principles in H.R. 3 the President is supportive of, but it has to pass both houses of Congress. And at the moment, H.R. 3 doesn't have a chance of seeing the light of day in the Senate, and so we need to work together to see if something can get through both chambers.
Well, I'm sure if the President asked Mitch McConnell to put it on the agenda, he would.
I don't think so.
There are plenty of things that we've passed in this House that unfortunately the other body hasn't done, and the President seems to be right along with it. So I just think it's another example of the administration's broken health care promises to the American people. I just think that we need to get those prices of drugs down, and we need to have not empty rhetoric, but true facts. And I yield back the balance of my time.
The gentleman yields back. Pleased to recognize the gentleman who was the former chairman of the full committee, Mr. Upton of Michigan, for his 4 minutes.
Thank you, Madam Chair. Mr. Secretary, welcome. Big time. So as you know, this committee on a unanimous vote passed 21st Century Cures, as we call it. When I was chair, we expedited the approval of drugs and devices, and I would suspect strongly that your testimony that we had a record number of generic approvals is a direct result because of what this committee did. We also added some $45 billion in health research over a 10-year span. And frankly, we asked the question of the agencies as we worked on this legislation, what is it that we could do to help you make sure that we hit these targets of faster approvals of drugs and devices? And so whether it was the FDA, the CDC, and others, The NIH, obviously, they gave us an answer, and we delivered. And at the end of the day, for this crisis, we are going to find a vaccine to solve coronavirus. I know that we are, and I'd like to think that what we did in this committee and then passed on the House floor will be a direct result of that. And frankly, it prompts all of us, I think, to ask the questions of what more can we do to get on a faster pace to find that vaccine and that cure. And in fact, as you may know, Diana DeGette and I are again working on a 2.0 cures bill where we can take these 3 years since President Obama signed the bill into law and ask those questions to see what constructively we can do so that all hands are on deck. And I know, don't have to ask you, I know that you will help us with ideas to do that. Question that I have is a containment in the very first step in responding to any outbreak of coronavirus. We've seen that around the world now. And statements from yesterday indicate that the CDC said it really isn't if, but when it gets to larger numbers here in the United States. I've always believed in the adage that if you're going to do something, better do it right the first time because you're not going to find a second. And and you want to make sure that pay me now or pay me later. So we need to have the right numbers as it relates to fighting this terrible disease. Is the $2.5 billion, is that a floor? Is that a suggestion, the $2.5 billion that you requested?
We have described the request as at least $2.5 billion for 2020 money, and then work on 2021 money as we see the situation develop over the weeks and months ahead.
So I know that we're waiting to see the precise details of where it's going. Are any of those dollars envisioned to include the contingency of what China has done as it relates to regional quarantines?
No, we don't envision that as a kind of practical step here in the United States. That we would, as Dr. Messonnier spoke about yesterday, in the event that we had community-level outbreaks, which might be small, just a town, a city, if we had that, we would take the pandemic book, which is community-based mitigation steps, social distancing. It is very rare that those types of cordon sanitaire efforts around cities, they are effective. They usually provoke more panic and cause people to actually leave and spread. Now, China's a different government and culture than we have here.
Of the 14,000 Americans that have died this flu season, do you know what percentage of those were not vaccinated?
I do not have the numbers. Historically, our youth who die tend to not to have been vaccinated, which is a real tragedy.
And the last question, there been any query of those 55 Americans who currently have been diagnosed with the coronavirus? Did any of them have the flu vaccine? You know, was that question asked of any of the 55?
I don't know that would have been asked. We don't, of course, have any evidence that the flu vaccine would have any properties related to the novel coronavirus, but I don't know if that was asked as part of intake for the patients.
Okay, I yield back.
Gentleman yields back. It's a pleasure to recognize the gentlewoman from California, Ms. Matsui, for her 4 minutes of questions.
Thank you, Madam Chair, and for holding this important hearing, and welcome, Mr. Secretary. Before getting to my line of questioning, I do want to express my deepest concerns about the Medicare, Medicaid, and other cuts included in the budget. At a time when we're dealing with the coronavirus outbreak, an addiction crisis, and a lawsuit that threatens ACA protections for pre-existing conditions, the administration's cuts to critical safety net programs target the most vulnerable in our communities and aim to further erode access to vital health care services. We should be prioritizing primary comprehensive care, particularly in the mentally ill and people with addiction. I believe mental health is an area where we have an opportunity to work together and make progress. Mr. Secretary, I appreciate the Department's strong support of the Certified Community Behavioral Health Clinic Medicaid demonstration. As you know, Representative Mark McMullen and I are working to further scale the program with our bipartisan legislation, the Excellence in Mental Health and Addiction Treatment Expansion Act. For the 8 states currently participating in the Excellence Demonstration, We have studies showing that quality mental health services, outpatient care, and addiction treatment provided at these facilities are saving lives and money. People are avoiding jails and emergency rooms, instead getting the comprehensive care they need in their communities. We have 11 additional states that are ready to participate in an expanded excellence program. Our bill has a bipartisan group of 88 co-sponsors who support this full expansion, and the House has already voted to extend the program longer term. I was very pleased to see that the budget this year explicitly endorses extending the excellence demonstration, and I believe we do all agree, Mr. Secretary, that adequate Medicaid resources around substance abuse treatment are essential to fighting the opioid and addiction epidemic. Mr. Secretary, I have a question. Under the leadership of Chair DeLauro's $200 million was made available to HHS in FY20 to help states prepare for eventual participation in the excellence demonstration. How does HHS plan to obligate these resources?
First, thank you for your personal leadership on the Certified Community Behavioral Health Center issue. That is, you're right, the data is showing really positive results to date, so thank you for that. In terms of your work with Chairwoman DeLauro, SAMHSA is now accepting applications from states for these grants to increase access to and improve the quality of community mental and substance use disorder treatment services through the expansion of CCBHCs, and the deadline for states to apply is March 10th.
Okay, thank you. The positive impacts of the demonstration make it clear that there's room to improve mental health and addiction care in this country by scaling this program. In California, our county hospitals, public academic medical centers, and public children's hospitals rely upon financial arrangements that leverage public funds and partnerships as essential means providing health care to the most underserved communities and patient populations in the state. I have concerns about the administration's recent proposal to eliminate these sources of funding, particularly supplement payments. I worry that if finalized, the Medicaid accountability rule will destabilize the whole system of care provided under Medi-Cal. Medicaid supplemental payments are an integral component of total Medicaid reimbursement that providers rely on for adequate reimbursement and financial stability. Mr. Secretary, have you weighed the restrictions on supplemental payments against the adequacy of these base payments? Are there plans to make any corresponding adjustments to base payments for these providers?
So we're hearing the very important feedback from you and others about that regulation, and we want to take that in as we look at how and whether to finalize at CMS on the relationship of these intergovernmental transfers to supplemental payments, and also if there are ways we can work with states to restructure payments in a way that would be consistent with the law. So we want to work with the states, not be adversarial to them on this.
Okay, but thank you, Mr. Secretary, and I yield back.
Gentlewoman yields back. Pleasure to recognize Mr. Shimkus of Illinois for his 4 minutes of questions.
Thank you, Madam Chairman. Thank you, Mr. Secretary, for being here. Coronavirus is a novel pathogen, as a lot of us know. But in your testimony, you also mentioned emerging microbial threats. And Madam Chairman, I'd like to ask to submit in the record this news release from the World Health Organization on the 17th of January, 2020.
So ordered.
And in the 114th Congress, I joined with Gene Green on what we called the ADAPT Act. Last Congress, it was Tony Cardenas and I, with the help of the now chairman of the subcommittee, Anna Eshoo, who joined, and technical assistance by HHS on what we call the Revamp Act. And it's an attempt to address how, if you have these antimicrobial resistance, how public funding may not be the only way you can address this. Can you talk about that challenge?
Yeah, I'm very concerned about the drug development around antimicrobial resistance in terms of creating a sustainable market. You know, we've had actually tremendous success from the efforts you've led and the Congress has led and BARDA at my agency have supported. We've supported development of 16 novel antibacterial projects. I believe 3 have actually come to market. What we're finding, though, is there's a market failure question here where you're basically asking a company to develop a drug, but then not to have it used much. And that's not a usually sustainable business model. So I've actually commissioned my team to work on how can we possibly solve that? Is that more like a bioterrorism chemical countermeasure and the approaches that we need there. Quite concerned about this situation.
And that's what we've tried to do legislatively, and at some time one was the tradable vouchers debate, which I think still should have legs, especially in this concern of, as you put it, trying to have something on the shelf that you don't want to use. That's the key. Scott Peters and I are also working on legislation that we call Ending the Diagnostic Odyssey, and it is an attempt to help DNA sequencing so that when there's a disease or some event, you don't have to test. You can go just through the sequencing aspect of that. Any thoughts on or comments of what you all may be doing that we don't know about in trying to push more DNA identification?
So I've not studied that particular issue. We're happy to get back to you on that. It certainly is at the fore right now as we deal with novel coronavirus and have the CDC diagnostic, but also hope that commercial innovators will develop physician bedside diagnostics for rapid in-site testing.
Yeah, and this is timely. Well, obviously it's timely because of the threat that we're all concerned about now, but it's also Rare Disease Week, and a lot of that community is looking for this as a novel way, especially on that, what we call that diagnostic odyssey, where they just, and we see that with people who are struggling with just types of cancer and trying to identify the right treatment early versus what I would say sometimes is a trial and error method that is very damaging to the health of the patient. And with 30 seconds left, I wanted to just briefly, and it's been asked a little bit before, you all do support Medicare D reform, is that correct?
Oh, absolutely. It's a real opportunity for seniors.
And how would reform lower patient out-of-pocket costs?
Well, you would cap catastrophic payment at the limit at $3,100, so a patient would never pay more than $3,100. And then, at least the Grassley-Wyden plan, the senior could actually opt into a program where they would pay no more than $258 a month for their drugs, no matter what their expenses are.
Amen.
Gentleman yields back. The gentleman from Maryland, Mr. Sarbanes, is recognized for his 4 minutes of questions.
Thank you, Madam Chair. Secretary Azar, you certainly know that the popularity of e-cigarettes has recently led to an unprecedented surge in youth tobacco use, and it's bringing back with a vengeance the tobacco epidemic in this country we've worked so hard to curb. It shows why we have to improve the law, and something that this committee has been working on. Unfortunately, the Trump administration is now proposing, as I understand it from the budget, removing FDA's oversight of tobacco products in favor of an untested agency that will take years to get off the ground, which threatens to set us back even further. I'm perplexed that the administration would decide to do this, remove FDA's authority, alter the agency's public health mission, which includes making, quote, tobacco-related death and disease part of America's past, not America's future, and by doing so, ensuring a healthier life for every family. This latest move is kind of breathtaking. It makes no sense. It's a crazy thing to do by the administration, which unfortunately hasn't taken significant action against big tobacco as more of our nation's youth are becoming addicted. In January, after heavy lobbying from big tobacco, as we understand it, and the vaping industry, and listening to partisan political consultants like Trump campaign manager Brad Parscale, the administration reversed course, and we were on a trajectory where we thought everybody was on the same page. The administration reversed course, announced a policy which failed to ban all flavored e-cigarettes, allowing popular menthol cartridges to stay on the market, and allowing all flavored disposable e-cigarettes and open-tank e-cigarettes to proliferate through our nation's schoolyards, which is exactly what they're doing. And I'm concerned that removing this authority from the FDA, which is part of the proposal, could lead to even more loopholes and more industry influence. My question is this: when formulating the budget proposal to remove the FDA's tobacco oversight authority, did you, your agency's staff, White House staff, or staff of the Office of Management and Budget speak or meet with any lobbyists or other representatives of the tobacco industry, or for that matter, political operatives who work for or are contracted by the president's reelection campaign?
Well, I can't speak for others. I'm not aware of any such deliberations. The idea was that if we move the Tobacco Center out from under FDA, first, if it were a presidential appointed Senate confirmed leader, they'd be more accountable to Congress. Second, as a direct report to me or whoever is secretary, elevating the role of tobacco control there. It has always been a little bit of an odd connection. FDA is about safe and effective, whereas the Tobacco Center is about regulating a product that is undeniably bad. And so there's a...
It doesn't make any sense, does it?
Well, it would, of course,
At
be
the
subject
height-
to Congress if it was something
I mean,
you all were
we're at the height of we're at this tipping point on this epidemic when it comes to vaping. I mean, there does reside, however you want to sort of carve up what you consider the appropriate mission of the FDA to be. There certainly resides within FDA now significant expertise and experience in terms of dealing with this issue. Why you would propose at this moment in time, when this epidemic risks, in a sense, overtaking the dimensions of the previous tobacco epidemic that we saw in this country, by zeroing out that authority and moving it to an untested new agency, which, by the way, I think would be more susceptible to political influence of the kind I was just recounting than it is now. It doesn't make any sense to me. I urge you to reconsider that. We are in the midst of this crisis, and we have to use every tool available to us here in the government to respond to it. With that, I yield back.
The gentleman yields back. There is 5 minutes and 22 seconds left on the clock. Any member that would like to leave to vote, when we get to, you can leave now. When the clock goes to zero, they will hold the vote open for those that have not arrived from our subcommittee, and at that point, we'll take a 20-minute break. But now I'd like to recognize the gentleman from Kentucky, Mr. Guthrie, for his 4 minutes of questions.
Thank you, Mr. Secretary. I look forward to getting into the coronavirus. I'm going to do my second round of questions. So the SUPPORT Act we passed last year included my bill, the Comprehensive Opioid Recoveries Act, to establish treatment centers that offer FDA-approved medication-assisted treatments, all of them comprehensively. Currently, SAMHSA has the grant application open for entities to apply, and I'm glad HHS is moving fast on implementing the program. But my question is, how is HHS implementing other parts of the SUPPORT Act, and does HHS conduct any oversight on how the funds are actually being used?
So first, thank you for the SUPPORT Act, and it is comprehensive. We actually established a SUPPORT Act Implementation Leadership Committee to track all of the different work streams needed under the SUPPORT Act. It's really enhancing our work across all 5 elements of our strategy on opioids, and so we're driving forward, making progress on the opioid epidemic. We got the overdose deaths are down for the first time in decades as a result of our collaborative bipartisan efforts here. And we're implementing and using the SUPPORT Act authorities, so thank you for those.
Okay, thank you. And also in 2018, Congress passed my bill, the Bipartisan Bold Infrastructure for Alzheimer's Act. Can you please provide an update on how this law is being implemented across the country?
With that act, I'd want to, if I could get back to you in writing on that. I don't have all the details on that particular program. I apologize, but if I could get back to you.
Okay, thank you. And then this is kind of technical from our role as ranking Republican on the O&I subcommittee for this committee, and this committee and O&I conducted extensive oversight, cybersecurity at HHS, including through technical audits conducted by GAO of cybersecurity controls at HHS operational divisions. So that says very technical. Last Congress, the subcommittee on oversight and investigations held a closed hearing in part because HHS failed to properly identify and address certain vulnerabilities. We recently received preliminary results from the most recent audit of another HHS agency, though I can't go into details in this setting. So my question is, does HHS have a point person who coordinates corrective actions on cybersecurity among all HHS agencies? And if so, we direct that person to continue to work with the committee on improving enterprise cybersecurity at HHS and ensuring that mitigations applied in one setting are consequently applied through all of HHS?
Yes, we do. Our Chief Information Officer, Jose Arrieta, who works directly with me, absolutely is in charge of those issues. If I could go back to your previous question, I'd misheard on the BOLD Act.
On BOLD Act, yes.
So I apologize on that. For fiscal year 2020, CDC will have two funding opportunities to carry out actions under the BOLD Act. So first, there'll be the public health programs to address Alzheimer's disease and related dementias. And second, there will be the health centers of excellence to address Alzheimer's disease and related dementias. We expect both of those funding opportunities to be out in the coming month. And for FY 2021, the President's budget for CDC includes $3.493 million to continue to support these Alzheimer's activities.
Because by 2050, that's when I'll be 86, I believe, they believe it's going to be estimate CBO, $1 trillion spent on Alzheimer's disease. Not only is it devastating to the individual who has it, the family that cares for that person, but also it'd be devastating to the deficit in the budget of our country. So this is something very important. Thanks for your leadership and effort, and I appreciate working with my colleagues here to move the BOLD Act forward and address it. And I yield back.
Gentleman yields back. Pleasure to recognize the gentleman from New Mexico, Mr. Lujan, for his 4 minutes. And I'll wait right here with you, and then we'll run over.
Thank you, Madam Chair. Secretary Azar, when Donald Trump was running for office 4 years ago, he famously said that he wouldn't cut Medicaid. He didn't say it once or twice, but claimed it at least 5 separate occasions that he would not cut Medicaid. But in reality, no president and no administration in the last 50 years has done more to undermine Medicaid than Donald Trump. In fact, his first major legislative effort to repeal the Affordable Care Act would have ended Medicaid as we know it and put the health care of 70 million Americans at risk. And if my colleagues from the other side of the aisle want to protect people with pre-existing conditions, they should drop the lawsuit. That could happen tomorrow. After President Trump failed to cut Medicaid legislatively, he decided to try the same thing administratively, even though the law clearly does not allow it. Secretary Azar, there's been some misreporting that the block grant guidance is limited to adults in the expansion population. But under the administration's guidance, states could block grant Medicaid for more than just expansion adults. Isn't that true?
Congressman, I don't believe that's the case. I'll ask the CMS administrator to get back to you on that, but my understanding was that it would be an optional demonstration for adults only and that it would actually not affect coverage for our most vulnerable, our pregnant women, children, elderly adults, people eligible on the basis of disability. But I'll ask Administrator Verma to get back to you on that because that is not my understanding.
Let me jump into this. I'm glad that you pointed that out because I believe that there is a concern here, and I hope that you would agree with me if that's your understanding, that you do something about it, Mr. Secretary, because the Center on Budget points out that people that are low-income parents, women who are pregnant, and people with disabilities who are covered through Medicaid expansion could be included in what I will describe as the President's illegal block grant guidance. Is that something that you would agree with if that's the case? Would you stop it if, in fact, the guidance does allow for those vulnerable populations to be discriminated against?
So I have been under the view that it does not affect coverage for our most vulnerable populations. It doesn't allow them to strip benefits, strip eligibility. Essential health benefits have to be covered. You can't change eligibility. You can't cap or limit.
So, Mr. Secretary, if I may, just for clarification, because it sounds like we're on the same page.
What you're saying, I'm not, the concerns you're expressing, I don't believe are in the HOA, but we'll get back to you on that.
Let me ask you this pointed question. If, in fact, the President's Medicaid block grant program does allow for those folks to be thrown off and get caught up in this, will you stop it?
Well, we're not going to approve plans that allow people to be thrown off because it can't change eligibility.
Let me ask the question one more time, because it sounds like you're getting there. Mr. Secretary, if in fact vulnerable populations like pregnant women, families, those that are disabled, are subject to this rule where they could be block granted, will you stop it?
I don't believe we would. I will not approve a plan that removes coverage for our most vulnerable citizens.
So that's enough for me. You said you will not approve a plan
with very low-income parents, children, pregnant women, elderly adults, or people eligible on the basis of disability should not be removed, should not be affected in terms of their Medicaid coverage, is what I'm informed. I'll get back to you from Administrator Verma to confirm all of those details. I want to make sure that I'm right on that, but that's been my understanding of the HOA program.
What I'm looking for is assurance that if what my comments are associating with being consistent with the center and budget points out, you in fact will not approve that plan, and you will not allow for Medicaid block grant cuts, devastating cuts, go into place that will be subjected to pregnant women, families, and those with disabilities.
The categories that I mentioned before are ones that I do not believe are subject to it, and plans should not be approved if they would harm eligibility for those individuals.
So if the Center on Budget's assessment is correct, you will not allow that to go in effect?
I do not believe their assessment or description of the program is correct, and I've said I don't expect that I would approve any plan that would harm our vulnerable populations. It is a healthy adult opportunities under Medicaid expansion, but we'll get you any clarification on that afterwards.
Well, thank you, Madam
Appreciate you
Chair.
raising that to me.
There's a reason that most of us in this Congress have opposed Medicaid block grants. These are devastating programs. It's another effort to undermine Medicaid and to continue to cut the program, which President Trump promised he would not. This is another example of where he is. And with that, I yield back.
The committee will now recess for approximately 20 minutes. So hold on to your seats while you stand up and stretch, and we race over and come back. Sounded like the secretary said yes, Ben Ray.
get, yeah, can I get a second to check it out?
Yeah, just go ahead.
The subcommittee will come back to order. Thank you, Dr. Azar, for your patience. And I now would like to recognize the gentleman from Virginia, Mr. Griffith, for his, is it 4 minutes? 4 minutes of questions.
Thank you, Madam Chair. Appreciate you being here. Thank you so much. The President and your agency have expressed concerns with the middlemen in the drug supply chain, pharmacy benefit managers, PBMs. Over time, PBMs have morphed into under-regulated entities with opportunities to exploit their position in the middle of the drug transactions in the U.S. For example, according to a new report from XIL Consulting, which is run by a former Express Scripts executive, PBMs benefit from an obscure fee known as direct and indirect remuneration, DIR. I know you're familiar with that, at a rate exceeding 500% per prescription as compared to the average administration fee. Last year, the administration proposed a rule to address these DIR fees, but later withdrew it. Do you still have plans to implement accountability measures for PBMs? And if so, what does that regulation look like?
So I remain very concerned about the DIR fees and their impact, especially on America's community pharmacists as well as independent specialty pharmacies. So the reason that we did not finalize that rule, and we were very transparent at the time, was the concern that if we forced the DIR fees to basically go through to the benefit of the patient, that could cause an increase. The middlemen would jack up the Part D premiums for our seniors, and that was the concern, and the President just has been adamant that he does not want to run the risk of Part D premiums going up. So it remains a priority for the administration to deal with this issue. If we ever could legislatively, that would be useful also.
Well, and as you know, I would love to have a legislative solution, but we thought this might be a good test case to do it with that.
Maybe even through, if we could get bipartisan, bicameral drug pricing legislation, that might be a vehicle to have that in there.
It might be, and let me ask you this. There's been some mention earlier today of H.R. 3. I raised the concern, and then later it was raised by the Congressional Research Service, that the bill as written is just blatantly unconstitutional. Have your lawyers advised you that that's the case in their opinion as well?
I've not had anyone study the constitutionality issues on H.R. 3 about the penalty amounts and whether that would work. So I haven't seen any analytics on that.
Well, anytime they want a discussion on it, I'm more than happy to facilitate one. Let's talk about opioids, because I only have a little bit of time left. Over the past few years, there's been a lot of talk about how they're prescribed in America and how pain is medically managed in general. And I will tell you that I thought we were on the track of getting our healthcare professionals to back off of giving out so many opioids for pain. But I have a friend who is currently undergoing some procedures, and we were talking yesterday about how they had given her turned it away, but they, she's got it sitting in her house. What has this administration and HHS done to reduce the overprescribing of opioids?
So we've actually, through the CDC, put out guidance to professionals on appropriate prescribing. We continue to work on even further titrated by different pain areas on what the best guidance is to do that. It's distressing to hear that. We've seen, though, an over 25%, I believe, decrease, maybe 30% decrease in the opioid prescribing of legal opioids to date since the President took office. So we're making progress, but of course it's disturbing to hear any pockets like that.
Well, and look, it's going to take time, but we can't, just because we've started to solve the problem, we cannot think it's solved, and we cannot take off the gas pedal and trying to make sure that we don't overprescribe, and then with that we deal with this issue. It's very serious in my district and many others. I thank you very much, and I yield back.
Gentleman yields back. The chair is pleased to recognize the gentleman from Oregon, Mr. Schrader, for his 4 minutes.
Thank you very much, Madam Chair. Thanks for being here, Secretary Azar. Appreciate it very, very much. I'm going to leave my coronavirus questions to the next panel, but we do want to make sure the CDC is fully funded, and a little concerned about the original budget. Glad to see some changes coming forward. My questions, first question is on Medicare Advantage. It's a huge program in Oregon and many, many states. Leverages our federal tax dollars to maximum advantage. Most Oregonians, most seniors get a lot of their prescription drug coverage from Medicare Advantage. Very concerned that this administration, and frankly others, have tended to try and cut Medicare Advantage programs. I think that's foolhardy. The whole goal here is to actually make sure that these savings from the Medicare Advantage are plowed back into making sure there are more benefits that are covered, better prescription drug coverage, and expanding it to a larger universe. So could you give me some assurance you're going to continue to, this administration, you will try and continue to improve the Medicare Advantage program and not take away the savings that can be plowed into more benefits for folks?
No, absolutely. So I'm actually under direct orders of the president in his Medicare executive order to enhance and protect Medicare Advantage, exactly the things you're talking about. Offer more supplemental benefits, make sure people make those plans as attractive as options for people as possible.
All right, just saw guidelines on reducing caps and that sort of thing that made me nervous about what the intent was. Second question's on the proposed Medicaid rule. Hear a lot about that back home. Many states, I was budget chair for my state back in the day, and seemed like a great opportunity for states to, again, leverage federal dollars with state tax dollars, actually with private hospital dollars and long-term care dollars. It was a really smart use, I thought, of taxpayers' limited ability to finance the programs they want. This really made great use of the dollars. I'm very concerned with this new MFAR rule that you're going, ostensibly it's with all due respect, framed in the guise of transparency, when indeed it's a backdoor attempt to take away matching funds, the ability for the provider tax to be leveraged in many states, including ours. So I guess given the fact the executive order requires federal agencies to perform this regulatory impact analysis to determine the effect of the impact of the proposed rule, but the proposed rule says the fiscal impact of the Medicaid program from the implementation of the proposed rule is unknown. Do you consider that to be a comprehensive regulatory impact analysis?
I haven't looked at the reg impact analysis there, so I don't know the specifics on that, but certainly I do want to assure you we are hearing the feedback from you and others and governors about this. We are looking at this not to be penal, but rather to make sure that those intergovernmental transfers are genuine state money that's getting matched and not funny money or schemes. That's really the intent, and to also be more prospective, not penal, looking backwards as much as we can. So I appreciate getting this feedback. We're hearing a lot of it, and we're taking that in.
Well, what some people would call funny money schemes, others would call smart financing, and using the accounting system the way it's been established for decades to maximum advantage, it would really put a huge hundreds of $million-dollar hole in the Oregon State HHS budget. So I'd urge you to back down on that a little bit, or at least give it some more serious thought. And I'll yield back. Thank you, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the gentleman from Florida, Mr. Bilirakis, for his 4 minutes of questions.
Thank you, Madam Chair. I appreciate it very much. Secretary Azar, thank you, first of all, for your leadership. I appreciate it very much. And thank you for your responsiveness to a lot of my constituents' concerns as well. Again, we've begun to make progress tackling our nation's opioid crisis, and HHS has played a key role in that effort. Thank you for your continued support, of course. Do you feel, and this is a budget question, do you feel HHS has the necessary resources to continue to implement provisions of the 2018 Support Act and the 2019 HHS Pain Management Task Force recommendations?
I do believe so. In fact, we've increased funding for opioids in this budget.
Okay, very good. Also, next, the community health centers, as you know, do a wonderful job. The funding is expiring soon. Now, we reauthorized it for an additional 7 years, and that's a great thing. But again, how do community health centers serve as a gateway to integrated care for individuals with mental illness and substance use disorder?
You know, more than 28 million people rely on HRSA's community health centers that we fund. They're a critical part of our primary care network of preventive care for individuals, and they deliver high-quality service. And we're using them also as part of the Ending the HIV Epidemic program to reach the underserved and reach people that we need to bring into treatment and prevention. More than 93% of our 1,400 health centers provide mental health counseling and treatment. 67% of them provide substance abuse services. I think the number is 60% of the clients of community health centers, I believe, are ethnic and racial minorities. I'm always just so impressed when I visit them, the quality of care and the quality of service there.
Absolutely. Do you have anything to add? Because I want to give you an opportunity to add, because this is a big issue affecting our constituents, obviously, on the insulin pricing. I know that this has been mentioned in committee, but if you could maybe elaborate on that, I'd appreciate it very much.
Well, I appreciate that. I did want to clarify one thing from Mr. Walden's question earlier regarding a piece of legislation. I misheard about, I guess it's a proposal to cap out-of-pockets at $50 for insulin. The administration does not have a formal statement of administration position on that piece of legislation yet. Of course, we want to get out-of-pockets down. We want to deal with the insulin issue and get insulin pricing down for everybody. But we don't have a formal statement yet on that issue. The Part D reforms the committee's worked on, and that has a lot of bipartisan support, though, that could be such a benefit to people. That catastrophic cap at $3,100, spreading that cap over 12 months where no senior would ever pay more than $258 a month for their prescriptions if they opted into that. What an incredible thing we could deliver for America's seniors if we could get bicameral, bipartisan action on that.
Absolutely. Well, thank you for clarifying that, and of course, we'll follow up with you, because again, this is a big issue affecting our constituents. How does the budget address school safety? I don't have much time, do I? How does the budget address school safety and the mental health needs of our students?
So we fund Project Aware in here, which is a really important school-based school safety program for mental health services. We have Healthy Transitions funded, which improves access to mental disorder treatment and related support services for youth. We have the Safe Schools Framework Implementation Toolkit to help educate teachers and administrators to identify kids in crisis who need mental health intervention. That's part of it.
Okay, thank you very much. I appreciate it, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the gentleman from Massachusetts, Mr. Kennedy, for his 4 minutes of questions.
Thank you, Madam Chair. Mr. Secretary, thank you for being here. This week, DHS implemented their wealth test for immigrants nationwide. The early estimates show that the rule could lead to 4.7 million people withdrawing from Medicaid and CHIP alone, many of whom are legal immigrants, the children of immigrants, asylum seekers, and refugees. Yes or no, sir, nearly 5 million people forced to forego their health coverage. Is that a success?
We do not believe that individuals who come to this country should be dependent on public taxpayers for health care or other services.
So refugees losing access to health care is a success?
We do not believe that individuals who should come to this country to be dependent on public welfare programs. That's the basis for that.
So, sir, you have frequently told the story of your grandfather arriving at Ellis Island from Lebanon as an impoverished teenager who spoke no English. You talk about him being met by a member of the United States Public Health Service. You speak proudly of that story. Under this rule, based on your own telling of that story, your grandfather would have been turned away. So I ask you, yes or no, are you proud of this public charge policy?
So my grandfather came and worked his way up through his bootstraps in
Would
the
he have
steel mills of Bethlehem.
Would he have had access to health care under this policy?
No, he would not have.
And
he wouldn't have asked for it because he would have wanted to make his own way.
And so you are proud of this policy?
I'm proud of my grandfather, and 100 years ago he came to the United States at Ellis Island.
That was not the question.
We
are you proud of this policy?
It's we believe the American people don't support the idea that people should be coming to this country to be.
Mr. Secretary, next question. Are you aware that under your leadership, the number of Americans without health insurance has risen for the first time in a decade in 2018 by roughly 2 million people?
So actually, the numbers on the uninsured require a bit more depth than that. What's happening on the uninsured is actually the ACA has most of the growth of uninsured is because the ACA priced individuals out of the individual market.
Sir, I'm not going to let you take my 4 minutes.
1.9 earned 2.
Are you aware, sir, Mr. Secretary, that the percentage of uninsured children rose by 0.6% under your leadership? And would you consider fewer children with access to health care a success?
So Actually, in terms of children and coverage, we have S-CHIP. We've reauthorized that for a long period of time. We've got the Medicaid program.
You can test the numbers.
So in terms of the uninsured numbers there, if the children that are uninsured are likely part of the coverage gap left by the ACA, as well as the pricing out of
And so, sir,
non-subsidized.
do you believe it's so last month, we held a hearing here about an opioid epidemic where a representative from the Department of Health and Human Services of North Carolina stated that if North Carolina had expanded Medicaid, 415 more people would be alive in North Carolina today. Do you believe that this administration's opposition to Medicaid expansion, that according to that individual has cost lives, is that a good policy choice?
I am not going to validate that politician's statements. I don't know.
It was a representative of the Department of Health and Human Services of North Carolina.
I don't know who they are. I don't know the basis for that. I haven't seen the evidence.
So you're unaware of the fact that Medicaid has saved lives in North Carolina, or the absence of Medicaid expansion?
That's not what I'm saying. I'm saying I haven't seen the evidence basis for the assertions you're making and that he made.
One last question for you. You've spoken about this administration's efforts to combat coronavirus and the so-called increased choice for healthcare. For one man, Osmel Martinez, asked you. Those two things recently converged when he tried to be prepared after developing flu-like symptoms following a trip to China. He was left with a bill of well over $1,000 and a demand of proof that the flu he was tested for wasn't related to any pre-existing condition, or else he would be forced to pay a few $1,000s more. So please explain to me, as we are staring down a potential pandemic and the CDC is warning about fundamental changes to our way of life because of it, do millions of people that have signed up for junk insurance plans pushed by this administration, do they really have a choice?
So the short-term limited duration plans are an option for individuals. We've been very clear that they may be the right choice for some, but they may not be the right choice for others who have pre-existing conditions.
Leaving people with thousands of dollars of uninsured claims in the midst of a potential pandemic, that's a good choice?
So if an individual, if it's a choice between no insurance and some insurance, it's 60% lower than what the Affordable Care Act has priced them out of the market at. It's at least an option for individuals.
Unless they expanded Medicaid.
Provide.
Yield back.
The gentleman yields back. Pleasure to recognize the gentleman from Indiana, Dr. Bouchon, for his 4 minutes of questioning.
Thank you very much, and thank you, Mr. Secretary, for being here today. I'm going to switch gears a little bit. 340B is a critical program, especially for rural hospitals. And I'm just interested in what you think should be done, if anything, to continue to ensure that the 340B program, given its significant growth, is helping more patients get access to care.
You put your finger right on it there when you mentioned the growth. It has grown from $7 billion of pharmaceutical sales in 2012 to $19.3 billion in 2017. And we believe in the 340B program, but we do believe those savings need to actually make their way to patients, not just subsidizing hospitals, but actually make their way to patients. I mean, imagine, for instance, just take the issue of insulin. Hospitals often acquire their insulin at an extremely low price, but they don't have to necessarily pass those savings on to the patient that they're serving as an outpatient. That's partly why we, with Part B, proposed the changes and have tried to implement the changes that would reduce what seniors have to pay for Part B, would have to pay in the Medicare program for their drugs.
Do you think that more transparency in the 340B program would be part of the solution?
Absolutely. We support transparency in the program. We support giving me regulatory authority as part of our budget, and also requiring that hospitals that want to get the benefit of those savings I just talked about to retain that in the program would have to dedicate 1% of their work towards delivering charity care, which seems like a pretty low bar.
So what you're saying is probably that HRSA does need probably more authority and more teeth to address the program. Would you agree with that?
We need greater oversight, but we need regulatory authority to implement that oversight so that we can actually do audits in an enforceable way and have that type of transparency.
Thank you. I'd also like to thank you for making improvements in pain management a key component of the HHS opioid strategy plan. I mean, I firmly believe we'll never successfully address the opioid epidemic unless we also improve pain management, and I'm a physician. And patient access to non-opioid therapies, particularly FDA-approved medical devices, which have the greatest opioid-sparing potential. Can you tell us what HHS is doing to promote pain management best practices and the status of various provisions in the Support Act to break down barriers to non-opioid therapies for pain?
So one of my top priorities has been to leverage the Center for Medicare and Medicaid Innovations authorities to fight the opioid epidemic. And that's why we developed the maternal opioid misuse, or the MOM model, and we recently announced the participants in that model. And that's going to address the fragmentation of care for pregnant and postpartum Medicaid beneficiaries with opioid use disorder by supporting care coordination and better integration. So that's part of that.
Great. And earlier in the hearing, you were starting to give some bullet points on, I think, Corona, your plan, the 5-point plan or whatever, in the last 50 seconds. Can you expand on that?
You bet. First, expand our surveillance system so we have novel coronavirus surveillance comparable to what we have on the flu, because that's the bedrock of our public health response. Second, money to support state and local public health departments are going to have to do a lot of work here. Third, vaccine research and development. Fourth, therapeutic research and development. And fifth, finally, strategic national stockpile acquisition, especially of personal protective equipment.
Thank you for that. And do you feel that we've had enough access in China to get the data that we need to help solve this problem? Is that loosened up?
We have struggled. The World Health Organization, Gorin team, has now completed its mission. We're awaiting its report. The initial reports I have is that team felt they were getting access to information and evidence, but I want to see the final results of that.
Okay, thank you, Mr. Secretary. I yield back.
Gentleman yields back. Just for the record, HHS has existing oversight authority of 340B, and it's my understanding that RISA has conducted 1,300 audits of the program. So
the courts actually have said we do not have the ability to implement regulations. So that
we're not talking about that. They were talking about audits, and so that's why I wanted to get this on the record. Look at your audits and see what's in them. It's under the control of your department. I now would like to call on or recognize the gentleman from California, Mr. Cardenas, for his 4 minutes.
Thank you very much, Madam Chair, and appreciate the opportunity for us to have this oversight hearing. Secretary Azar, thank you so much for being with us. There's an opportunity for us to ask you some essential questions in fulfilling our oversight duties. And last time you were here before us for a budget hearing, I asked you about your agency's role in the horrifying practices of separating children from their families. Today, I'd like to ask you about other ways that the administration is impacting families, both in my district and throughout the country. I'd like to ask you about an issue that is frightening families in my own district. I'm, of course, talking about the for-profit company's proposal for a detention center in my district, a proposal approved by HHS and that wants to use our federal tax dollars to put a facility there to have children in a prison-like setting. Vision Quest, the company that received these funds from your agency, has a history of alarming reports and stories of abuse within their programs right here in this country. These stories include descriptions of excessive use of physical restraints and isolation, verbal abuse, food deprivation, humiliation, and intimidation, and even deaths. And this is all about them having children in their care. As part of the due diligence of your organization, would officials within the Office of Refugee Resettlement be aware of these types of violations before awarding a contract to such a company like Vision Quest?
I don't want to endorse the statements that you've made regarding that entity because I do not know the particulars of that entity or the allegations that are being made there. So I want to be careful that I'm not endorsing that. But
okay,
I would expect that it would be part of any grant review of any grantee to examine their past history, treatment of children. I would absolutely expect that, yes.
Okay, if you could please report to this committee if any of the grantees, such as the one that I was talking to, if there's any evidence within the department of any valid situations with an organization such as an organization that would be entrusted with federal funds to house children. Okay, thank you. But the funds, these funds that you'll be providing, unless you were to have such evidence, you would go ahead and contract with an organization?
Well, that's how, as you know, the Unaccompanied Alien Children program runs, is we hire grantees that run permanent, hopefully permanent state licensed facilities that care for children until we can place them with sponsors. That's really what the system Congress set up. That's what we run.
Thank you. And the city of Los Angeles is in the process of solidifying their ordinance as to whether or not they're going to allow private entities to use federal funds to house children. I have another issue I'd like to discuss with you. I want to turn to the issue of impacting American families, especially vulnerable children throughout America. In your written testimony, you speak about the importance of promoting adoption to give children the stability and love during their childhood. You speak about prioritizing adoption, but you neglect to mention the fact that right now in America, the agencies are turning away qualified potential parents because they are either LGBTQ or they happen to be of a religious minority here in America. This is in spite of the fact that LGBTQ parents are 7 times more likely to foster or adopt children than non-LGBTQ parents. My question is, in your efforts to identify and address barriers to adoption, can you tell me how eliminating data collection and reporting on sexual orientation over foster and adoptive youth and parents is helpful to furthering that goal?
So the AFCARS, what you're referring to, I believe, is the AFCARS reporting system. And the original regulation contained 270 individual data points, 153 of which were new. And the states, there was significant feedback about just the sheer volume of data collection and expense to states, all of which is money that if we add more and more questions, more and more data collections, that's money the states can't use to actually assist with adoption and foster care placement. So it's really just an effort to streamline those data requests in there.
My time's expired, I yield back.
Is the gentleman yielding back? I thank the gentleman. Pleasure to recognize the gentlewoman, and that she is from Indiana, Ms. Brooks, for 4 minutes.
Thank you, Madam Chairwoman, and welcome, Secretary Azar. Thank you for being here. And thank you for pointing out that just this past June, the President signed PAPA, the reauthorization of PAPA, of which this committee worked very hard on in the last Congress, and we finally got it done in this Congress. I worked particularly hard with the chairwoman and the ranking member of this committee to try to make sure we improved our readiness and our response, and because the question of a pandemic is really not a question of if, but when. And I think most people, and obviously CDC is acknowledging that. One thing I'd like people who are listening to understand, the Global Health Security Index was recently issued, and the United States of America was first in the world out of 195 countries for prevention, detection, response, and public health. And also want to commend the administration for the National Health Security Strategy that was put in place for 2019 to 2022. I want to commend you for leading that work. But with respect to PAPA, I'm curious, how are you leveraging, how is HHS leveraging all of the new things that we put into PAPA? And then I have one I'd like to also ask you to address, because there are so many good things in your budget, but I am particularly concerned about a $200 million cut to BARDA, because BARDA has brought forth so many incredible innovation and the partnership that they have with the private sector. Given this proposed cut, what strategies are we going to put in place if BARDA is cut?
So on the BARDA question, so that was, of course, in the budget before the coronavirus situation. And because Congress in the appropriations in December added, I think, $535 million of Ebola funding available in 2020, we were pulling forward some of our acquisition strategies from BARDA into 2020 around especially vaccine and therapeutics on Ebola. And so that created some offset. We may need to relook at that now, given some of the offsets proposed in the supplemental request. But that was meant to be somewhat because we had pulled forward some of those acquisition strategies to 2020.
Okay, but the private sector companies who are our partners in developing the diagnostics, the therapeutics, the vaccines, and because the government is the customer for those products, is it fair to say then that BARDA and all of the BARDA professionals who are working in BARDA, is it fair to say that they should not anticipate with what is happening right now a cut in their funding?
we would work with the appropriators as to whether the offset we proposed on the 535 Ebola to be part of the funding of the supplemental, if that happens. I can tell you from feedback this morning at the House Appropriations Committee, I think that may be unlikely from the appropriators.
Because we still have Ebola in Africa, is that correct?
We do, although fortunately it's definitely on the downswing on the epi curve at this point. But what we would do is use that money for acquisitions on Ebola, if that money remains there for Ebola in 2020 vaccines and therapeutics that we've got. But if not, we'd work with appropriators on making sure BART is adequately funded, certainly.
And are there any other issues or any other strategies or framework that we provided in PAPA that you are using specifically right now to combat the coronavirus?
On the coronavirus, I can't trace directly to the PAPA authorities, but for instance, our vaccine strategies are very much influenced by that in terms of recombinant DNA, the universal vaccine research that we're doing in the influenza case, as well as cell-based technology to bring domestic manufacturing capabilities here.
I yield back my time. Thank you.
The gentlewoman yields back. Just for the record, the gentlewoman asked about the $200 million cut to BARDA, and the secretary responded. The administration, Mr. Secretary, put out the budget 10 days after, not before, after declaring a public health emergency. So your answer is really not correct on that.
Well, I'm sure you understand the budget is locked in December, so it's already probably was printed by the date of the coronavirus outbreak.
Well, you mean the administration doesn't have the ability to call it in and cross something out and say, no, we're not cutting this, we need it? I mean, that's not, come on. All right, now, the gentleman from Vermont, Mr. Welch, is recognized for 4 minutes.
Thank you, Mr. Secretary. I've been here a while. Drug importation, we're very happy that you're proceeding on that. And as you know, we have a Republican governor in Vermont who's extremely interested in getting authority to do this. And they hope to have everything that's required for you sooner than the deadline. So we think it's a great opportunity. Our Republican governor and Democratic legislature wants to take advantage of this. One of the concerns that the governor has in particular, but all of us, is including insulin, and that's not included. And my understanding is that there have been some concerns raised as to whether that can be safely done. It really would make a huge difference to Vermonters. And as you know, a lot of people already drive across the border to get insulin, and even some companies do that. Our view is that the concerns about safety are always legitimate, no matter where the source of drugs. But our real request is to accommodate insulin as one of the drugs that could be imported as long as it's done safely. I wish you could comment on that and tell us what we need to do to give some relief to folks that are desperate about the cost difference.
So unfortunately, insulins as an injectable product are expressly excluded under Section 804 of the Food, Drug, and Cosmetic Act, which is the provision for the Canadian importation regime that we're using. We have no objection to it. In fact, the second part of the importation program where a drug company could bring a product in with a new drug code and actually price it at a lower list price so that they could deal with their PBM, those middlemen contracts that encourage high rebates. That's open for all products, including insulin.
So let me just understand, this is helpful. You're saying it's because of the statute?
Yes,
not because of a concern that HHS has?
It's the statute.
So as far as you're concerned, if you felt there was authority under law for insulin to be included, you'd see no reason to object to that?
That's correct. We would be supportive if the statute provided for that. We believe it can be imported appropriately, but the statute does not allow me to approve an importation regime under 804 with insulins in it.
So if we did an amendment to the statute to allow for insulin to be an exception, you'd be supportive of that, it sounds like.
I can't formally state an administration position, but I can tell you the president wants importation. He wants it yesterday, and we're delighted the governor is working because We want shovel-ready importations programs that when we finalize a rule that we could get to work on improving.
All right, so who would I follow up with in the administration? Probably sounds like you, but
Me.
you might have to talk to the president about supporting what statutory provision may need to be included in order to allow insulin to come in. That would be huge, huge, huge for the governor of Vermont and for the people of Vermont.
Happy to work with you on that, absolutely, and talk directly to the president with you.
All right, thank you. And I yield back. Thank you very much, Mr. Secretary.
Gentleman yields back. The gentleman from Georgia, Mr. Carter, is recognized for 4 minutes.
Thank you, Mr. Secretary, for being here. I want to follow up on Representative Griffith's questions about DIR fees by the pharmacy benefit managers. And of course, as you know, the PBMs have squeezed out almost $4 billion out of pharmacies, out of retail pharmacies with these DIR fees. And the survey that was done by the National Community Pharmacists Association said that 58% of the independent retail pharmacists in this country don't expect to be in business in 2 years as a result of DIR fees, which of course should be of concern to all of us, but particularly to HHS and the delivery of healthcare services in our country. I just wanted to ask you, I believe you responded to Mr. Griffith by saying that the concern was the higher premiums with the insurance companies. As you know, 3 PBMs account for almost 80% of the market share in this country, and all of those PBMs are owned by insurance companies. How can we answer the question of whether those rebates that they are getting, the PBMs are giving, are going back to the insurance company that is also owned by the same company?
Well, that's one of the real problems we've got is we don't have PBM transparency. Absolutely. So we can't actually know where those monies are flowing.
It would appear to me that that's just taking money out of one pocket and putting it in the other pocket. I mean, it's the same company, and then it's extended even more than that to include the pharmacies as well. So, the vertical integration is something that's got to be addressed. But what do you think we can do to address the DIR fees? Now, the DIR fees have been associated with higher out-of-pocket costs for recipients, and that's certainly something we have to be concerned about, and I know you're concerned about, and you have said in the past that you are. But if we can lower out-of-pocket costs, would it help to have the rebates at the point of sale?
Oh, yes, it would help to have rebates at the point of sale that would lower out-of-pocket costs and pushing through, so folks understand the DIR is basically a penalty provision that the middlemen impose on the community pharmacist, but the patient is made to pay off of the full price when they buy the drug, and the pharmacy later may get this clawback of this penalty, but the patient doesn't get a refund of their out-of-pocket.
Absolutely, and that clawback can take place almost a year afterwards, and sometimes 2 years after.
Very unpredictable to the community pharmacy. They're struggling from this,
Absolutely, absolutely. Now, I want to switch to coronavirus, and these are yes or no questions, if you could answer them for me. At this time, are you and others involved in preparing for a potential COVID-19 outbreak, doing everything you can to prepare for such an event?
We are indeed.
At this time, if you and others involved in preparing for a potential COVID-19 outbreak felt like you needed more money, would you have asked for it?
I would have, and I have, and that request is there.
Okay. At any time, if you and others involved in preparing for a potential COVID-19 outbreak need more money, will you ask for it?
I will indeed.
Absolutely. So it's not as to say that the amount of money that is asked for is proportional to the effort that's going to be put forth to prepare for this.
Right. That's right. And the president has made very clear in my own discussions with him as well as publicly that we want to work with Congress on an appropriate supplemental appropriation here. And we've said, it quite deliberately says at least $2.5 billion. We want to work with Congress. We've got to get that money and make sure that the Congress is satisfied with the funding also.
As it should be the case. And again, and you find out that you need more, you're going to come back to us and we're going to approve it. We want you to have everything that is available that you need to prepare for this, and you're going to do that, correct?
That's correct.
Madam Chair, I yield back. Thank you, Mr. Secretary.
Gentleman yields back. Chair recognizes the gentleman from California, Mr. Ruiz, for 4 minutes.
Thank you, Secretary Azar, for being here today. As a father and a physician, I care very deeply about the physical and mental health of children, and also children while in the custody of the Office of Refugee Resettlement. And I'm glad my colleague Tony Cardenas brought that up because I'm also dealing with a similar situation in my district. ORR's website says their unaccompanied children program, quote, takes into consideration the unique nature of each child's situation, incorporates child welfare principles when making placement, clinical, case management, and release decisions that are in the best interest of the child. So let me get this straight because I definitely want answers. When determining appropriate housing for children in ORR custody, do you give grants to for-profit organizations with a documented history of child abuse?
Again, I can't speak to that particular grantee that was raised before. We would give grants to for-profit and nonprofit without discrimination.
So the
but
caveat is those with a documented history of child abuse. I recently learned that in addition to the facility in Arleta, California, ORR is providing a grant to Vision Quest to open a 130-bed shelter for unaccompanied children in the city of Hemet, California, which I represent. Vision Quest is a for-profit organization whose history suggests that their focus is to make money rather than care about the well-being of children. This is exemplified by Vision Quest's very long history of keeping children in abusive and harmful conditions, which my colleague touched on. Dating all the way back to 1987, a report from the RAND Corporation found that, quote, the treatment methods used by Vision Quest were unorthodox and that activities engaged in by the youth posed unnecessary risk to their health and safety. Last year, the Associated Press reported that in 1994, the Department of Justice documented episodes of physical and mental abuse at a Vision Quest shelter in Franklin, Pennsylvania, including staffers pulling children's hair, using harsh restraints, choking minors, and even slamming them into walls. And in 2017, the city of Philadelphia had to end a contract with Vision Quest after state inspectors found that staff members had choked, slapped, and injured children in the facility. Secretary Azar providing federal funding to a for-profit organization with a long history of child abuse is definitely not in the best interest of children. Are you familiar with these reports?
I'm not familiar with all of those reports. Some of the allegations that you raised, I am familiar with. Of course, whether for-profit or nonprofit is not the factor, but we want to ensure that any grantee. Thank you.
A letter within the Department of Justice.
Thank you. I appreciate that. I appreciate that.
My question now.
Gentlemen, be seated and speak from the microphone so that what you say can be properly recorded.
Will do. So now.
As I just note from 1994.
Of course.
But we want to make, we will make sure any grantee is appropriate to the care.
That's why I mentioned a long history of abuse.
Well, we need to make sure
that's why,
correct and not
that's why when you look and review at these programs, I want to ask you, what is the process? Is there transparency? How do you determine and how do you open this up to communities to determine who's going to house children with the safety of these children in mind?
So for these permanent bedded facilities, which is our goal at the request of Congress, the grantees would actually have to be state licensed. And so there's a state licensure procedure. That would be
the
state
of Pennsylvania denied them their ability to take care of children because of those horrible.
And then they would not be able to be a grantee.
And they had to close that facility. So the question is, when you look at those reports and you review the evidence, would you be open to reevaluating these grants and your relationship with Vision Quest
I will
in their care for ORR?
I will ensure that ORR has looked at these, and this was part of the evaluation criteria in looking at them. Of course, just because an entity, as all of the behaviors you described, are absolutely unacceptable. I just want to be very clear about that.
And I'm glad you said that, because
absolutely unacceptable.
The gentleman's time has expired. The chair recognizes the gentleman from Missouri, Mr. Long, for his 4 minutes. We really need to move along because we have another panel, and everyone knows it's a very important one. So let's stay on within our time. Mr. Long, 4 minutes.
Thank you, Madam Chairwoman. And Secretary Azar, I want to thank you for being here today. I know we tried to get together one time, and as soon as we sat down, my phone started blowing up that my house was on fire in Missouri, which it turns out it wasn't, but the alarm company people seem to think it was, and they sent the fire department. I'm sure you remember that. But I want to thank you for working so hard to advance the administration's health agenda on behalf of the American people. As you note in your testimony, rural Americans face many unique health challenges, and under your leadership, HHS created the Rural Health Task Force and is proposing a 4-point strategy to transform rural health, which is vitally important in my areas. I represent a lot of rural areas. Can you first speak to the Rural Health Task Force role in identifying the needs of rural areas and how to meet those needs department-wide?
Yes, absolutely. Thank you. The Rural Task Force identified 4 key priorities for us. The first, we've got to develop a sustainable model for rural health care. We can't just patch it over with money if it's not underlying economically viable. Second, we have to have prevention and health promotion in rural America. Third, we've got to leverage technology and innovation like telehealth. And fourth, we've got to get the next generation of providers out into rural America. And we've got to allow nurse practitioners and PAs to practice to the full extent of their license in rural communities.
Okay, thank you. And one area in rural health that's been seriously impacted over the last few years is durable medical equipment, as you're apprised of. I was pleased that CMS issued the interim final rule in May of 2018 that provided payment relief for durable medical equipment in rural areas and continued the relief in the 2019 end-stage renal disease final rule until the end of 2020. Can you tell me if CMS plans to continue this relief in rural areas after 2020?
So I'm not able, obviously, to discuss the pending regulatory action, but do know that that was a major priority to get that payment fix in place through the interim final rule to ensure better equity for rural America. So that remains very much top of mind for us.
Okay. And in the President's fiscal year 21 budget, there's a provision that would expand the competitive bidding program for durable medical equipment into rural areas in 2024. We have heard many complaints about the competitive bidding program over the years, really since its inception. Can you detail how you would like to reform the program and how it would impact rural areas?
Yes, what we would like to do in the budget is actually pay for durable medical equipment under the competitive bidding program and move that, though, from a single payment amount that's based on the maximum winning bid to actually paying suppliers on their own bid amounts, and then expanding the competitive bidding to additional geographic areas, including rural areas. We think that would actually enhance access to DME in rural areas by allowing competition there rather than simply having to depend on the payment results secured elsewhere. We think that can solve a lot of the access challenges that we saw that we had to work to fix with the interim final regulation.
Okay, and has CMS engaged with outside experts, economists, or consumer groups on this as it considers expanding the competitive bidding program?
We do. We engage with stakeholders and experts before we consider any new policy, and of course, the benefit when we do notice and comment rulemaking is to get that feedback.
Would you go forward with the proposal without congressional approval?
I believe for some of the regional elements on competitive business, I believe that I don't know if we require statutory authority. I want to get back to you on that as to whether the budget has that as an administrative action or a statutory request. If I could get back to you, Congressman, on that.
If you would, I appreciate it,
Yeah,
and
thank you.
I yield back.
The gentleman yields back. The chair now recognizes the gentlewoman from Michigan, Ms. Dingell, for her 4 minutes of questions.
Thank you, Madam Chair. Thank you, Mr. Secretary. I know it's been a long afternoon. It's been nearly a month since you declared a formal public health emergency in response to the coronavirus global threat. On February 2nd, you sent a letter to Congress that you intend to use or transfer or reprogram authority to reallocate approximately $136 million from current programs. Yesterday, we got the details of those transfers, and I'd like to request unanimous consent to enter that into the record.
So ordered.
Thank you, Madam Chair. These include $62 million transferred out of NIH, $37 million taken from the Low-Income Energy Assistance Program, and $7.5 million from the Centers for Medicare and Medicaid. Given that you plan to take $37 million from the Low-Income Energy Program, do we have any estimates of how many people that's going to impact and who are going to go without heat this winter?
So for the transfer and reallocation authority, that works out to a 0.2% change, and we did that across the department evenly, but then within different agencies that they selected various programs. On LAHEAP, we are now late in the season, almost at the end of February. I don't have an analysis.
Can we get for the record, please, what we think the impact will be, because we obviously are worried about people who aren't going to have heat. You're going to take 60, and I don't mean to be, I just have to go fast. I have 4 minutes. You're going to be taking, you took $62 million from NIH. Is that going to harm our ability to conduct medical research and do new cancer treatments? I'm happy with you that opioid deaths have gone down this year. There's no one who feels stronger, maybe Annie, we're together, and meet other public health challenges. What's going to happen to those programs?
So the NIH, in doing the reallocation and taking their allotment of the 0.2%, they firewalled off certain priorities, including, I know opioid research and development is one of the priority
So it has
areas,
not been cut.
Pediatric cancer, right.
All right. Now, I know you talked about this yesterday, but you stated in your Senate testimony yesterday that the U.S. currently has about 30 million stockpiled N95 respirators, which are masks that can help stop a person from inhaling ineffective particles, but that it might require 300 million for healthcare workers alone. This doesn't include masks, gloves, and personal protective equipment. That was yesterday. We've heard about nearly 900 more cases worldwide, 60 more deaths. Your own agency, I'm really worried, as I know the chair is, about the supply chain in this country. Your own agency has stated that 65% of N95 respirators are manufactured outside of the U.S., in China and Mexico. Yesterday, the Washington Post told us that a large group purchasing organization says we may only have a 2-week supply. I don't want to frighten anybody. We shouldn't be rushing off, but are we facing an imminent shortage of N95 respirators and other personal protective equipment?
So I did want to clarify on the numbers. I told the appropriators this morning this. After the hearing, I learned some additional information about the number of masks that we've got. We have a higher number, but the mix is different. So we have 30 million surgical masks, the gauze masks. We have 12 million N95 NIOSH certified masks, and then 5 that are not NIOSH certified, 5 million N95. So I just wanted to clarify the data on that. One of the things we're doing with the transfer money that we discussed earlier is contracting to get contracts started with domestic manufacturers of N95 masks so that we can scale up production.
But how long is it going to take to scale up that production?
It will take time because we do not have as much domestic
Is it a national security threat that 90% of our generics are coming from China? We've got this kind of shortage. What are we going to do, and I'm out of time, to help bring the kind of production of these kinds of essentials to this country so we're not dependent on anyone else?
Gentlewoman's time has expired. Who's next? No one on the Republican side? Okay. The chair recognizes the gentlewoman from Delaware, Ms. Blunt Rochester, for 4 minutes.
Thank you, Madam Chairwoman, and also welcome, Mr. Secretary. I have to express my deep concern and disappointment in the implementation of the Affordable Care Act, which is the law of the land. It appears that the Department of Health and Human Services has made it harder for Americans to access and afford the vital health insurance coverage that they rely on. Your department recently proposed a rule that would discontinue the ACA subsidies for low-income families who do not actively reapply during the ACA's open enrollment period. These are low-income Americans who are currently enrolled in $0 premium plans. Secretary Azar, your department's analysis acknowledges that there are 270,000 Americans who are re-enrolled in these $0 premium plans that would lose or could lose their coverage. And yet these proposed ending auto enrollment for these individuals, thereby endangering their coverage. First, a yes or no question. In deciding to propose this policy, did you consider the fact that it would result in American families losing coverage?
I want to get back to you for the record if I could. I don't know that we actually proposed it as opposed to ask for comment on whether one should allow auto re-enrollment for people that are 100% subsidized in the ACA exchange markets. I think we asked just for comment on that as opposed to proposing that as the approach.
So I'm assuming if you're asking for comment, it's something that you're considering?
It's under consideration if we should require someone to apply who's getting 100% of their subsidy paid for, their premiums paid for, should they affirmatively demonstrate that they continue to qualify on an income and wealth basis for that. as opposed to just rolling over and then pay and chase later if we find months later they don't qualify.
So can you guarantee that no individuals would lose coverage as a result of this policy?
Well, if they don't qualify, then they wouldn't retain coverage at 100% subsidy.
Meaning if you change the policy, then they wouldn't qualify and then they could
shouldn't
lose.
qualify.
I'm particularly alarmed that your department would propose such a policy given that Congress statutorily directed you to establish automatic re-enrollment for all individuals enrolled in the marketplace. That provision was signed into law by the president at the end of the year. This proposed policy goes against congressional intent. Mr. Secretary, will you commit to the American people that you will not take any action that would cause American families to lose their health insurance? That's just a yes or no.
I believe that rider was with respect to 2020 monies, and the request for information was regarding the 2021 plan year, which is not subject to that rider, is my understanding.
The deep concern is that the department now has a record of refusing to properly invest in robust advertising and outreach. The department has drastically reduced funding for outreach and education activities. It's gutted the Navigator program, limited the time for enrollment, and is giving consumers less opportunity to make informed choices. Now the department threatens to disclose American families' subsidies, to discontinue American family subsidies who have become accustomed to being re-enrolled every year. Mr. Secretary, would you commit to working with me to ensure that Americans wishing to enroll in coverage will be well informed about the opportunities to enroll?
Well, I'm always happy to work with you, Congresswoman.
Well, we talked about working together before, so I just want to put it on the record on this particular issue.
So we, just in terms of open enrollment, we put out 1 billion reminder emails. We had 6.
It's just a yes or no question because my time is expired. Yes.
Happy to work with you.
Okay, we will follow up. Thank you, Mr.
Gentlewoman's time has expired. The chair recognizes the gentlewoman from California, Ms. Barragan, for her 4 minutes of questions.
Thank you, Mr. Secretary, for being here today. As we have heard from you, our U.S. government has implemented aggressive measures to help prevent the spread of the coronavirus. There have been repatriation missions, there have been travel bans, airport restrictions, and additional travel notices issued. Many of these actions have impacted Los Angeles County, and in particular my district. On February 2nd, the President signed a proclamation banning foreign nationals who've traveled to China in the preceding 14 days and were not immediate family of U.S. citizens and permanent residents. Over the course of a few weeks, 808 U.S. citizens were flown back to the United States, where there were quarantined for 14 days at military bases. As of today, 37 countries have confirmed cases of coronavirus. Should we expect travel bans from countries like Italy, who have confirmed cases of transmission but are on a different continent than current travel bans? Mr. Secretary, how sustainable are quarantine and travel restrictions in holding the coronavirus at bay?
It's an excellent question, and that's why when we did the initial 212F China ban that you mentioned, we were very clear we can't hermetically seal the United States off, and at some point there would be sufficient spread in other countries that measures like that would not be effective. With China, of course, with the epicenter being in China and with the aggressive measures taken by China, that's what we felt it was appropriate to do there. We'll constantly look at other travel advisories, 212F restrictions, or surveillance and requests for home isolation as we gather more information. But it's a very fair point, absolutely.
And so following up on that, what resources are going to, what resources are going to the quarantines that are happening?
So,
and should these be expanded? Should they be extended? What additional resources do you expect are going to be necessary?
So I would actually like to get us out of the federal quarantine business, and I do want to commend California and the local governments there. They've really been a superb partner with us on the repatriation of American citizens. But it is quite expensive to maintain institutional quarantine. We don't envision further repatriation flights. That really has implicated that need for us to scale up this type of facilities-based quarantine. In the future, as I think Dr. Schuchat mentioned yesterday, we'd envision more self-home isolation activities, state and local-based monitoring and quarantine activities.
Okay, I want to drill down a little bit on this, because on Monday, HHS issued a statement that revealed a naval base in Ventura County, Point Mugu, may receive American travelers coming through LAX who would be quarantined to be monitored for symptoms of coronavirus based solely on their travel history. Let me repeat that, based solely on their travel history. Mr. Secretary, what are HHS's plans to quarantine Americans based on solely their travel history? And would those be voluntary or mandatory?
So that would be the Hubei province travel. So an individual who within the previous 14 days has been in Hubei province in China as an American or a permanent resident alien or family member would be subject to mandatory quarantine. We're seeing very, very few of those individuals. I think we had a family of 3 and then 1 individual, or really all I believe that we have right now currently in quarantine. So that's more of a backup concept there, the Ventura facility you're talking about, to know it's there. But we've, again, worked very well with the state and locals in California.
Right, and we certainly know that the CDC has said that it's not a matter of if the virus is going to spread, but a matter of when. You know, Congress wants to work with your agency to fund adequate and effective and sustainable public health responses. We can't do that without sufficient funding going forward to appropriate to state and local partners. I know that you'll be seen out of the Congress, especially out of the majority proposal on that. Thank you, and I yield back.
Gentlewoman's time has expired. The chair recognizes the gentlewoman from New Hampshire, Ms. Custer, for her 4 minutes.
Thank you, Madam Chairman, and Secretary Azar, thank you for appearing before our committee. There is a lot going on, both in your budget and with our concerns about the coronavirus, so I'll move through this quickly. The key to a public health crisis, as you well know, is trust and credibility, and my point is it would be helpful for clear, easy to understand, credible updates from this administration to both us as policymakers and members of Congress and to the American people. And it would be even more preferable if the statements by the President of the United States did not contradict the statements of the scientists and physicians at the CDC and in your department. My time is limited. I want to jump right in on the administration's continuing efforts to undermine the Affordable Care Act's consumer protections for people with pre-existing conditions. The administration and your testimony today claims to support protections for pre-existing conditions, but with all due respect, the facts speak for themselves. This administration has repeatedly taken action, including court proceedings, to undermine protections for people, including my constituents, with pre-existing conditions. Your department finalized a rule to expand junk plans that do not provide protection for people with pre-existing conditions, and issued a 1332 waiver guidance creating new standards inconsistent with congressional intent. The guidance allows states to increase consumers' costs, reduce coverage, and undermine protections. Simple yes or no question, Secretary Azar, are you aware that the 1332 guidance could substantially raise costs for Americans with pre-existing conditions?
Actually, our 1332 guidance allowed me to approve reinsurance waivers for 11 states, causing 10 to 30% declines in premiums in
and
the
in the
exchange
other
market.
states, what would the result be?
One other state was, I think, I forget if it was Hawaii, that we approved a waiver allowing them to not have the shop, I think that was, if I remember correctly, was it Hawaii? Yes, in Hawaii. So that was at their request to not have the state, I forget the exact terminology of what the shop is, but it's a technical aspect of the Affordable Care Act. We've approved no other 1332 waivers at this point.
And will you commit not to approve waivers that would jeopardize the health and well-being and the financial well-being of Americans with pre-existing conditions?
You can't waive the protection against pre-existing conditions under 1332 or otherwise.
And this administration is inviting states to make changes to the ACA subsidy structure and direct taxpayer dollars to junk plans, and those do indeed threaten and jeopardize individuals with pre-existing conditions. Yes or no, do you think it's appropriate to allow states to direct taxpayer dollars toward junk plans that do not provide protections for pre-existing conditions?
We think it's appropriate to allow states to support access to these short-term limited duration plans, which are plans that the Obama administration allowed to 12 months up until the end of the administration.
Let me dive right into that. under the Obama administration, the short-term limited duration plans were for just 3 months. You've now extended it to 12 months with 3 renewals. That's not the same condition?
I'm afraid that's actually not correct. The Obama administration had them for up to 12 months up until the very end of the administration when they passed a midnight regulation shortening it to 3 months.
To 3 months, that's my point.
Right at the very
So,
end. They were perfectly fine with it.
My point is,
throughout.
it was 3 months, and you have allowed for extensions for up to 3 times. That is 4 years, and we had people testify here that they did not even have notice that their pre-existing conditions were not covered, and even insurers that said to them that if they didn't know they had a pre-existing, that they should have known. So this is something we need much more work on. I am to protect consumers with pre-existing conditions. Thank you.
One correction, it's 12 reinsurance waivers, not 11.
The gentlewoman's time has expired. The chair recognizes the gentlewoman from Illinois, Ms. Kelly, for 2 minutes. And I just want to instruct the members, we have 2 more to question, and they've agreed to limit their time to 2 minutes each. We will then take a very short break, maybe 5 minutes, to reset the witness table for the next panel and allow the secretary to take at least a few-minute break. All right, so now we'll recognize the gentleman from Illinois, Ms. Kelly, for 2 minutes.
Thank you, Mr. Secretary, for being here. I wanted to talk about 2 issues that I've paid a lot of attention to and have actually ravaged communities of color across the nation. One is maternal mortality, and the other is gun violence. President Trump has expressed concerns about maternal deaths, and following mass shootings last year, he called for bipartisan solutions to reduce gun violence. But we in Congress have come up with bipartisan solutions for both. I've worked with my colleagues on the other side of the aisle on a bill to expand Medicaid to provide postpartum coverage for a full year, and Congress appropriated and President Trump signed into law $12.5 billion in funding for the CDC to study gun violence. Yet, your administration seeks to slash funding to and block grant Medicaid, implement more restrictive eligibility criteria for Medicaid recipients, and completely zero out funding for gun violence research. Secretary, are you aware, yes or no, that the budget contains a proposal that would allow states to impose an asset test on pregnant women in Medicaid? It's pages 112 to 113 of the HHS budget in brief.
I'd want to look at that and get back to you on that. I'm not aware of that particular provision.
Okay.
We do have the proposal similar to what you just mentioned for Medicaid that would allow states an option to cover pregnant women for 1 year after birth if they're suffering from substance use disorders. That's another part of the maternal mortality initiative.
Yeah, that proposal would cut Medicaid funding by $2.2 billion. That's because it would cause a lot of people, including pregnant women, to lose their Medicaid coverage. So maybe you can't answer.
So that's a spending provision. The one I just mentioned, it would actually expand. Right now, they can only get 60 days coverage postpartum. This would allow that coverage for up to a year as a state option in a non-budget neutral way, I believe.
Well, my time's up.
Gentlewoman's time has expired. That legislation that we took up here is awaiting floor approval of the gentlewoman has been a leader on this for long before the rest of the members even knew that we had this horrible statistic in our country. Last but not least, the gentlewoman from Florida, Ms. Castor, for her 2 minutes.
Thank you, Madam Chair. Mr. Secretary, the administration is urging the federal courts to strike down the Affordable Care Act in its entirety, including the protections for more than 130 million Americans who have a pre-existing health condition. I think my neighbors back home would want me to relay to you how dangerous that is, how angry they are about it. They do not want to return to the days when insurance companies could discriminate against them if they had asthma, a cancer diagnosis, some other pre-existing condition. They don't want to return to the days where an insurance company can cancel them if they get sick. And I think the coronavirus now highlights the importance of consistent health insurance coverage that has a floor of essential health benefits, and it really shines light on these junk plans. The Your department has finalized a rule to expand the short-term limited duration junk plans. They're not required to cover pre-existing conditions. You acknowledged that in your last budget hearing in front of this committee. And a couple of studies have come out recently, a Georgetown Health Policy Institute study, one commissioned by Leukemia and Lymphoma Society that kind of highlights the abuses here. Is the department conducting any oversight on the abuses of these junk plans, the abuses in marketing, false promises? Are you conducting oversight of these?
So the short-term limited duration plans are off exchange, and so we don't
Could you just say
actually
yes or no
regulate.
quickly, 'cause
We don't
the time is short.
We don't regulate them directly. They're subject to state insurance regulation.
You do not, so you're it's like hands off. You said, we're gonna promote these junk plans, and you're not conducting any oversight. Is that true, yes or no?
They are subject to state insurance regulation as individual
And you don't
markets
check
should
in with
be.
the state and monitor the abuses in the junk plan market
We
that are
don't.
raising costs on everybody and excluding pre-existing conditions?
So
Thank you.
we do not support, we do not regulate state insurance commissioners.
Gentlewoman yields back. Let's take a 5-minute break, and the staff can reset the witness table, and then we'll resume. Thank you.
Did you ask somebody?
Hey, so good to see you again. Sorry, my number was
I get it.
Thank you.
Okay.
Here's the.
The Subcommittee on Health will come back to order. What we're going to do is, we're not going to have our witnesses do their formal public statements. We have them all in the record. We thank you for them. I've actually read them, and I'm sure my colleagues have as well. What I just want to do quickly, out of respect to each, is to just give a quick introduction, and then we'll go to members with their questions. And first of all, thank you for being here. I think that the United States of America is so blessed to have, I think, the finest public health professionals in the entire world. And the world, there's a reason why the world looks to us, because we have you and your expertise. So, Dr. Fauci, thank you to you. We just, America can't live without you, really. Dr. Hahn, welcome to you. I think this is the first time that you're before the committee, and we'll make it really pleasant for you. We won't do to you what we did to the Secretary. Mr. Secretary, welcome back to the table. Dr. Kadlec, welcome to you. And to Dr. Redfield from the CDC, thank you for being here, and thank you for collectively for what you've done to help to brief the Congress during this. Now, is it my turn to ask? Yep. Okay. Let me start with the, obviously with the coronavirus. I started out earlier today saying that confusion is the enemy of preparedness. I do not put confusion at the doorstep of Dr. Fauci, Dr. Hahn, Dr. Kadlec, and Dr. Redfield. I think that you have done an excellent job in advising, briefing the Congress, and for the work that you're doing. I think we have some problems with the administration because the professionals say one thing, and then there's confusion on the other side. I hope that something else will happen too, and that briefings be held in public so the American people can hear you. I hope as we move through this challenge that the American people will come to know you the way we do, and that we elevate the level of confidence and trust that I know you can engender, but I don't think it's there now. There's confusion. Markets are roiling. It's not only because of confusion, but there are many matters at hand. But you, the scientists, the doctors, the American people couldn't be better served. They just couldn't be better served. So thank you to you for your especially important service right now. What I want to get to, Dr. Hahn, let me start with you, is our drug supply. Are manufacturers being forthcoming with the FDA about potential shortages?
We're being, Madam Chairwoman, thank you for the question. We are being very proactive in our discussions with manufacturers. As you know, drug manufacturers are required to report to us when there are potential disruptions.
And how far in advance do they let you know that there will be a shortage?
Typically, those conversations occur in real time. What we've done is...
I know that, I think usually all of our conversations are in real time. I'm saying how much, in a trajectory of time, if they were talking to you today, would they be able to tell when the shortage would begin? How much runway do we have?
We often do not.
Example, China and manufacturing. So we have a problem with that.
So just as an example, I can tell you that drug manufacturers are required to tell us when there's a potential disruption to the drug supply. When the applicants apply to the FDA, they might provide, for example, 5 different manufacturers for the precursors to the drug, and then 5 manufacturers for the actual final drug form.
Let me ask you this. If the corona virus outbreak is continuing 3 months from now, and I pray that it isn't, what do you estimate the American drug supply will be? Have you done
we have looked at this.
Forward-leaning
There are
planning?
183 prescription drug manufacturers in China. 20 are sole source from China. That's both precursors as well as the final drug form. We've reached out to all of these manufacturers, and we have no shortages to those sole source drugs. It's the redundancy, Madam Chairwoman, that's most important. And if we have redundancy, then we can shift to other manufacturing sources.
The FDA, yesterday the FDA said you mentioned this, the 20 drug products that are either solely sourced there for their active ingredients or finished drug products from China. Can you share that list with us, or is that proprietary?
That's a proprietary list. We are internally compiling lists associated with all the questions that we've been asking of manufacturers.
Dr. Redfield, how many coronavirus tests can the U.S. conduct as of today?
How many cases?
Yeah, how many tests can our country conduct as of today?
I would have to get back to you with the exact number.
Okay. I kind of teased, but I was serious, Secretary Azar. We have some deep cuts to these agencies, the people that you're sitting with. And it was mentioned by, I think, the ranking member that the budget was printed and it couldn't be changed because of the print and all of that. I think, Secretary Azar, the $200 million in cuts at BARDA, $700 million in cuts at CDC, and $3 billion out of NIH. Are you willing to reconsider that, given what our country is facing and what the American people need day in and day out from these agencies? They are the essentials.
The proposals to the budget do not impact our ability to do the novel corona response. The CDC budget actually has a $135 million increase in the fields of infectious disease.
Do you think that, in other words, they deserve these cuts? These are healthy cuts. This is good for them, and it's good for our country.
You asked me about impact related to novel coronavirus. These will not impact functioning related to that. And of course, we have the emergency supplemental request on top of that.
Yeah. Well, but if you wrote it in December, how do you know that?
Because the changes that we make in the budget are not related to categories that will impact our ability to do the novel coronavirus response.
So there's nothing to reconsider?
I don't believe there is in terms of the existing budget proposal. We have
Well,
the
you
emergency
know what?
supplemental
It's,
adding to accounts that we think
Today
are
is
the relevant.
February 26th, 2020, and I certainly hope you're right. But I think that we're shortchanging the American people. This time to recognize Dr. Burgess, the ranking member of the subcommittee.
I think the chair, would just point out, we are the United States House of Representatives. All spending bills originate in the United States House of Representatives, so it's certainly well within our power to provide the level of spending that you all request. The House is just now doing its budget, several months after the administration did its budget. I will be testifying to the Budget Committee tomorrow. I think if people have concerns, they ought to bring them up to the Budget Committee. I just hope we will actually have a budget debate and vote on a House budget, because we haven't in several previous years. But I do want to thank the panel for being here today. This is critically important. The chair is correct that people do need to see, and this needs to be public. That's why we have hearings, because hearings are on the record and are public, which is why several weeks ago I suggested we have this hearing, and I'm glad we're having it today. Secretary Azar, you were testifying on the budget before. You did take some questions on the issue of the Office of Refugee Resettlement. Just off the topic of Corona, can I say I have been fortunate enough to visit a number of your facilities provided by Office of Refugee Resettlement, and I think we are fortunate to have the men and women who are working in those facilities, and would you just please convey to them my thanks, because I do think they do a good job, and we would be much the worse without them.
I will, and that will mean a great deal to them. Thank you.
Dr. Hahn, you and I had talked a little bit somewhat earlier about the supply chain and the active pharmaceutical ingredients that we import from overseas, and the fact was that there was an adequate stockpile as sort of this story began to evolve several weeks ago. What or to the extent that you can tell us, how are things looking now as far as the stockpile that companies have available, as far as the active pharmaceutical ingredient?
Thank you, Representative Burgess. As we discussed before, we've received no reports of shortages and found no shortages in prescription drugs coming from China. And we have discussed this with manufacturers and pharma companies, and adequate supplies currently exist.
So can I just offer this observation, since, and I've been on this subcommittee for a long time, and we've had this discussion in other guises in other times, and if there's ever any silver lining to this cloud, it may be that we recognize that we need to bring some of that manufacturing back within our own shores, so that we're responsible for we have the responsibility for that, for those active pharmaceutical ingredients. And I know this is something the president is focused on, and part of his rebuilding of America. This is, I think, work that this subcommittee has done in the past. I think it's something that we really need to take very seriously. We had some hearings on continuous manufacturing a few weeks ago, and I think that is another aspect of this where perhaps some attention to the continuous manufacturing, but the main thing is make it here, so we're not dependent on a sole source from another country, whether it be in difficulty from an infection or just simply out of sorts with the United States at the time. It does jeopardize our people, and I do think we need to recognize that. And again, that's not a criticism of this panel. We have known about that on this subcommittee for a long time, and it's just we haven't acted. Now perhaps we will. Dr. Redfield, I would like to ask you, and it's heard several times, the World Health Organization was able to finally get into China and assist them, and now that report is going to be coming back. Are you satisfied with the level of interaction that you've had with your Chinese counterparts? Because the CDC itself was not allowed to go in, is that correct? It was only as part of the World Health Organization?
We were able to have a representative on the Gorn team that went to China to do the investigation. I've had regular conversations with my counterpart, the head of the CDC in China. We've had good exchange of scientific information. We do have a CDC office in Beijing, China, that's there, and they continue to have good interactions with those colleagues.
So you think there is working with the state and local folks?
There's good scientific interaction between us.
And Dr. Hahn, let me just come back to you for a moment, and thank you for the the work you're doing on getting a laboratory-developed test, that is critical. They can't all be done at the CDC. We're going to have to be able to get those tests done rapidly in the field for our people on the front lines. But to the extent that, is there any evidence that there's any sort of hoarding behavior going on with things like personal protective equipment or pharmaceuticals? Is that something about which we need to become concerned?
In terms of the supply for,
Yes.
yeah, we have reached out to manufacturers, and we're aware that spot shortages can and have occurred. However, currently we know of no overall shortage related to PPE. However, this is a very dynamic situation, as I mentioned at yesterday's press conference, that we are likely to see some pressure, particularly on the demand side here.
Is there
We're
anything
working very closely with manufacturers on this.
Okay, is there anything you can do to prohibit or prevent, not prohibit, but prevent hoarding activity by people who might just be buying up equipment?
Well, the department has led an all-department effort to communicate to providers and hospitals regarding this issue, and we have recommended following CDC guidelines with respect to the use of particularly respirators, where it seems to be the most pressure.
Okay, thank you.
Gentleman's time has expired. It's a pleasure to recognize the gentlewoman from Colorado, Ms. DeGette, for her 5 minutes of questioning.
I thank the chair for including some of the other subcommittees in this. As 4 of the 5 of you well know, right, that we've been having hearings in the Oversight Subcommittee for years on these issues. It's what keeps me up at night. The most recent hearing we had was on December 4th about seasonal flu and pandemic flu. And lo, here we are. And what I'm concerned about is we're still not any more prepared than we were on December 4th. And so that's what I want to talk about. Back in 2005, we had a national blueprint for biodefense, or 2015. Some of you recognize this document. Our now colleague, Donna Shalala, had your job, Mr. Secretary, and in this blueprint for defense, what they did was they said we need to have it, in case we have some kind of a pandemic, we need to have a clear line of authority to make these decisions. Are you aware of that, Mr. Secretary?
I wasn't aware of Secretary Shalala's recommendation.
But are you aware that of this blueprint?
I'm aware of the blueprint. I wasn't aware.
Okay.
I wasn't
Well,
remembering that recommendation.
So this is what I want to ask you, because I just got back from Japan on Monday, and so we were really looking at the Diamond Princess incident. And here's what I was concerned about is you had all these people sitting in this petri dish of a ship for a long time. The CDC said that people should not be flown back to the U.S. from that ship. And then apparently the CDC was overruled by the State Department. So here's my question. You're the chairman of the President's Task Force on the novel coronavirus. Who's in charge? Are you in charge?
I'm in charge, but in Japan, the deputy chief of mission, who is the chargé d'affaires, who
Right.
made that decision, has full authority of the President of the
Right.
United
So
States
that's-
in a foreign country.
That's the problem.
No, that-
Well, yeah, it is, and I'll tell you why that's the problem. Because you're the head of the panel. The health experts are saying you shouldn't be flying these people back in, and then there's another agency that basically overruled what you said. If we have an outbreak in the United States, there are a number of other agencies that are going to have other interests. And I'll just give you a couple of examples. The State Department, which we just dealt with, HHS is you, the state public health departments, various other agencies. Who is in charge of the final verdict? Is it you?
It depends on the circumstances.
That's not gonna work if we have a pandemic.
If it's in a foreign country, the ambassador of the president is the final word on representing the United States interest in that country.
So what happened is they flew back in 14 Americans, maybe more, who were infected with the coronavirus. That's why someone needs to be in charge. And you know what? I think it should be you.
with respect, the deputy chief of mission had a very difficult decision to make there.
I understand that. I don't need you to explain that to me. What I'm saying is this goes along, there needs to be someone who can overrule Homeland Security and state who can make these decisions for the American public based on public health. And I'm hoping we can have some more hearings to talk about that. Dr. Redfield, I want to ask you, because the Chairwoman Eshoo asked you the question about the lab tests, and you didn't know, you said you didn't know how many lab tests are available. Do we have lab tests that will accurately test for the coronavirus?
Yes.
Okay, now what I heard was they're limited, and people have to send their test to the CDC to be tested. Is that right?
Presently, there's 12 jurisdictions that have the test up and running.
12 jurisdictions throughout the United States?
Throughout the United States.
And so people can send their tests there?
And
when are we going to be able to put that everywhere?
Well, we're working cooperatively with
I'm asking you, when are you going to be able to put that everywhere?
I was trying to say, we're working with the FDA now. We're hoping that later this week, our test will be such that the first one can go, all the laboratories that got it can execute the current test on the modification that we did with the FDA.
Okay. Dr. Fauci, I know you're working on developing a vaccine. If we gave you more money, could we develop a vaccine more quickly?
We would need more money to take it for the next step. We're in a phase 1 right now, and we're okay.
How much more money? How much more money? I think you could probably get bipartisan consensus that would give you the money.
Yeah. How much would you need to get it over the hill? About 140 million.
140 million.
Right.
And Congresswoman, if you wouldn't mind, the emergency supplemental would actually dedicate $1 billion for vaccine. Just that's part of the detail we'll be working with the committee on.
Okay, I just want to say one more thing because my time is up. And I know that Congresswoman Schakowsky is going to ask you some questions about the supplemental. I just want to say that even Minority Leader McCarthy today said we need at least $4 billion. And we shouldn't be shifting money away from Ebola and other diseases into trying to deal with this coronavirus. We need to work on all fronts at once. And I thank you for your comment, and I yield back.
Gentlewoman's time has expired. The gentleman from Kentucky, Mr. Guthrie, is recognized for his time.
Thank you, Madam Chair, and thank you for all being here. And just so everybody knows, we've been having these meetings, if they're not been formal hearings, bipartisan with several of you over time. And I remember when we first started meeting about this, it might have been Dr. Fauci, I said I don't want to put words in your mouth if you didn't, but we are going to prepare for a pandemic. That's what the American people expect us to do. We're going to prepare for a pandemic. We're going to put things in place for a pandemic and hope and pray that it never comes. We're going to get ready. And as we prepare for it, people are going to see things, hear things, and maybe react that this pandemic is imminent when it may not be because we're doing what we're supposed to do. The other thing is, I know the White House and the administration needs to reassure markets and marketplaces where we are and where we stand. And for everything that I've heard previously and what Larry Kudlow has said is not inconsistent, is where we are. But I know that the CDC came out and talking about the pandemic to be ready for it. And Secretary Azar, if you'd like to explain this, I know the CDC warned that Americans should, and I'll quote, prepare for community spread in the United States and should be ready for, quote, significant disruption. And would you explain what that means, what it means to the average person, what that means, and what's the most important message you would like for the American people to know about the current state of America and the coronavirus?
Our messaging from the president through to the career officials at the CDC has been consistent, but it's striking a balance. America's risk is low at the moment. That could change quickly. We are working to keep that risk low, but we have always been transparent that we expect more cases in the United States with a rapidly spreading virus, especially with what we've seen. For the average American, there's no change in their behaviors except what we always would advise, which is practice good public hygiene, washing your hands appropriately, coughing into your arm, not touching your face with unwashed hands, and appropriate preparedness activities at home. And you can go to cdc.gov for normal advice for flu seasons, hurricanes, and others. Good preparedness, good thoughtfulness at home. We're trying to be very transparent to people of the risks we face. even if we're at a low-risk situation now, so that so people aren't surprised, so that they know what we're dealing with and what uncertainties we're dealing with.
Thank you. And so Dr. Fauci and Dr. Redfield, for 50 days, we've learned much about the coronavirus, but much is still unknown. What is the current, that's what I know people want to know at home, what is the current scientific consensus about the transmissibility, infectiousness of the virus, and how long, once you're infected, will you be infected, how long can you pass it on? And what are the other remaining known unknowns? What are the things you know that you would like to know the answer to with Dr. Fauci and Dr. Redfield? Or Dr. Cadillac, if that's in your world?
First of all, we know it's a very transmissible virus. There are some viruses that are not efficient in going from human to human. What we learned early on, and we are convinced now, given what we've seen in China and other countries, that it's a highly transmissible virus. That's the first thing. The second thing, when you say how long a person is infected after they get infected, that's something that's still up in the air. And the way you get the answer to that is you try and isolate virus, what we call shedding, for a period of time. And we know that there are individuals who are actually able to transmit when they are without symptoms, before they get symptoms. What we don't know yet, and I think we're going to get information from the group, including the CDC individual and one of my people who was in China with the WHO group, what the extent of that transmissibility is from an asymptomatic person. Is it minor, part of the driving of the outbreak, or is it significant? That's going to be a very important thing that is currently an unknown. And Bob, you want to take up?
I concur with Dr. Fauci. I think the biggest challenge we have right now is what is the relative infectivity, whether before you get sick, are you more infectious before you get sick, or are you more infectious after you get sick? We are tracking these patients that we do have in this country to see how long they actually have a virus that can be isolated from their respiratory secretions. It's probably going to be longer than many of us originally anticipated. I think at this stage we have an individual's out about 18 days from the time they initially actually got sick. So I think these are key questions, and we continue to try to get the data to answer them.
So are there other things that you are looking to know that you don't know, that you know that you don't know that you're trying to find the answers to?
Well, I think one of the other areas from the CDC's point of view is try to understand the methods of transmission. Is it all respiratory transmission through droplets? Is there fomite transmission? For example, can this virus survive on certain surfaces long enough for somebody else to come down, put their hand down, and then touch their face? You know, it's not clear right now what the relative components of, say, droplet transmission is to fomite transmission.
Thank you. My time's expired. I'll yield back.
The gentleman yields back. Where are we? Oh, I see. The gentlewoman from Illinois, Ms. Schakowsky, is recognized.
Thank you. As all of you know, the World Health Organization has declared the coronavirus outbreak a global health emergency, and our administration now has declared it a public health emergency. Yet, Secretary Azar, we've talked about this, you've heard about it. The Trump administration asked Congress for just $2.5 billion to combat a disease that the CDC's director, Nancy Messonnier, warned could severely disrupt daily life and could severely and could cause severe illness in the United States. So in that request, you did not, as I understand, include, we're not specific about surveillance for testing kits that actually work, because not all of them have, and for treatment. Instead, you suggested robbing $500 million from the United States response to Ebola epidemic, which actually still is raging in places. So I find it incomprehensible that you're asking for a molehill when what we really need is a mountain of support here. Secretary Azar, yes or no, do you agree with the President of the United States that the coronavirus is very much under control in the United States, unquote, and will, quote, go away, unquote, by spring?
He did not say the last part that you just said. He said, we hope it will go away with warmer weather. I hope everybody here would hope it would go away with warmer weather. The virus in the United States has been in a contained situation to date, but that can change. As Dr. Messonnier said, we expect more cases, and we expect that we will see at least limited community transmission of the virus in the United States.
Let me ask you another question. My hometown of Chicago reported the first human-to-human transmission of the coronavirus in the United States. And though the Illinois and Cook County and Chicago Departments of Public Health have expertly, I would say, handled over our two coronavirus cases, they have not received any reimbursement or financial assistance for the work they've done. I just met with the Director of Public Health in Chicago, who said they're spending $150,000 per week to respond to this. Will the United States be able, in the $2.5 billion, be able to help local and state health officials who have already spent lots and lots of money trying to deal with this?
So yes, that is actually part of the supplemental request, is to fund state and locals, in addition to the $675 million FEP money they already have received for many years. Illinois, of course, received each year $16.3 million for exactly these activities, but we want to give additional funding through the supplemental request for those activities.
Well, that's really good news. Thank you. Secretary Azar, will your $2.5 billion be enough to help healthcare workers in hospitals and nursing homes, or the home care workers who have to care for quarantined individuals?
In what respect are you asking?
Well, I mean,
salaries, because they're already paid. I'm just curious. I want to.
No, I mean,
if there are elements we need to add to our request, we'll be glad.
There may be a lot of
Congress
additional costs that people that work in hospitals, and they may have to hire more people. Is there any help that's going to be for staffing?
Would you mind if Dr. Kadlik responds?
I can address part of your question, ma'am, and that is $350 million is dedicated for personal protective equipment that could be used by healthcare workers in many different settings. So we have that, we're stockpiling that to make it available should communities need that, in addition to what they have on hand.
Okay. Let me just finally say this. Last week, 45 of my colleagues and I sent a letter to President Trump, and what we were talking about is, are we going to be guaranteed an affordable treatments or vaccines that are developed? We're concerned that private pharmaceutical companies may end up having a role in this and raising the cost beyond the point that people could well afford it.
We absolutely share your passion around ensuring affordable access to medicines, but the private sector must have a role in this. We will not have a vaccine, we will not have therapeutics without the private sector candidates that they and we will have to invest in.
But we have paid for all of the R&D so far, right?
No, that's not accurate. For instance, the Gilead has a product, remdesivir, that was originally NIH-funded basic research, I think, out of University of Alabama, but they've carried forward with development. Moderna is using Dr. Fauci.
My time has expired, but if I could just reaffirm, then you're saying it will for sure be affordable for anyone who needs it.
I'm saying we would want to ensure that we work to make it affordable, but we can't control that price because we need the private sector to invest. The priority is to get vaccines and therapeutics. Price controls won't get us there.
Mr. Secretary, thank you. I now recognize the gentleman from Michigan, former chairman of the full committee, Mr. Upton.
Thank you, Madam Chair. I've got a couple questions I hope to run through, and I guess the first question ought to be directed at, first of all, thank you all, 24/7, and for the briefings that we've had over the last couple of weeks as well. I guess this ought to be directed first to Dr. Redfield. There's a report just published now in the last hour or two. Apparently there's a daily newspaper in Korea called the Jungang Daily, and they reported that there is a Korean Airlines flight attendant who serviced a number of flights between LAX and Seoul, and she was confirmed to have coronavirus. She also, they're not sure where she got it. There's some suspicion that she had also worked a flight to Israel with that apparent tourist group that came from Korea there in the previous week. What do you know about this? Is there some communication? I hope you know something, but I know that it's recent news. But it was published Tuesday in Korea. It's Thursday now. So just wondering what you might know about this.
I can say that I haven't been briefed on that, sir. Normally what we would do if we had confirmed cases, obviously...
Now, this is a Korean woman,
yeah, so
24 years old.
Yeah, so that would be, we are interacting. We actually sent someone yesterday to embed in the Korean CDC to help facilitate communications between Korea CDC and our CDC. But I can tell you I haven't been briefed on that specific situation, but I will look into it and get back to you.
Okay. Second, does anyone else know anything more? Dr. Fauci, I know that China did publish, thank goodness, the genetic sequence, which has allowed the rest of the world to try and pierce the bubble here. Moderna Therapeutics is one of the companies, I think they're out of Massachusetts, that is actually working on, I want to say a phase 1, but I may be wrong.
Yes.
Where, if it's successful, how long, what can you tell us?
We're working with the company Moderna on a vaccine platform called messenger RNA. We're working at our vaccine research center, and we did exactly as you said. As soon as the sequence was put on a public database, we pulled the gene out for the spike protein, which is the protein that you want to make an immune response against. There are several steps in that determine the success or failure of what you're doing. And we've been able to successfully express it in this particular platform that we're going to use for a vaccine. We have shown that it's immunogenic in mice, and very soon, within the next month and a half to 2, it's going to go into humans, and as in a phase 1 study. But I think people need to appreciate, because there's often misunderstanding. A phase 1 study, we'll say, was 3 months from the go, which was about a month and a half ago. It'll take about 3 months or 4 to determine if it's safe and induces the kind of response that you would predict would be protective. Once you get there, it relates to the question that I was asked before, then you go to a phase 2 study. The phase 1 study has 45 people. A phase 2 study has hundreds or maybe even low thousands of people. That would take at least 6 or 8 months to show that it works. So from the time you push the button to go to the time you even know it works, it's about 1 year to 1.5 years. Then, as the secretary said, you have to partner with pharmaceutical companies to make millions and millions and millions of doses, which could also extend the time.
And that would be a vaccine or a remedy?
That would be a vaccine to prevent infection.
Okay. Last question I have, and I'll save this for Secretary Azar. A couple weeks ago, my colleague Debbie Dingell and I sent a letter to the administration. You were copied on it as it relates to the supply chain of companies with operations in China, specifically Wuhan province. A lot of us are concerned about products that are made there. Auto State, Michigan, we got a lot of different things that are there. I know Apple, as an example. They fessed up, their stock price collapsed and led to the market trouble that we had this week. What type of outreach have you initiated outreach to companies, large and small, particularly on the shortage questions as well, because they may not want to tell you what they might know. So where are you all on that?
So as chair of the task force, we've directed a whole of government outreach to manufacturers and suppliers across not just healthcare, but everywhere. And Dr. Hahn and Dr. Kadlik have led the effort with regard to pharmaceutical, generic, and biologic and device manufacturers in China. And that's what Dr. Hahn was reporting on earlier, the results of that outreach. Very proactive. As you know, with drugs, they have to report to us potential shortages. Device, we don't yet have legislation on that, so we're proactively probing that system. As he reported, we don't yet know of any potential shortages, but we're on that because we share your concern about the risks there.
But just to follow up on, is Secretary of Commerce, are they working at other things,
Yes,
other than
yes.
beyond just drugs and devices?
Yes, with their regulated entities and their major manufacturing entities, they're working to gather information about potential shortages as they might impact the economy. The National Security Council, the National Economic Council are leading those efforts.
Thank you. Yield back.
I appreciate what Mr. Upton raised overall, but certainly the last part of it, the whole issue of our dependence on China, and that 90% of the American people take generics, and that those generic drugs are manufactured in China and to a lesser degree in India. But China controls the global market on the API, the active pharmaceutical ingredients. But I met with Dr. Kadlec after, I think it was the classified briefing. He came to my office. What I wanted to know was, do we have an inventory? Do we have an inventory of who the manufacturers are? Are any of these plants shut down? I know we asked questions about how long they can manufacture until they can't, and because drug shortages are a part of this whole problem with the supply chain. But when I met with Dr. Kadlec, we don't have that inventory. Is that in place now?
Actually, I believe,
Mr.
that's what Dr. Hahn briefed you on earlier.
We do have an inventory?
We have reached out to the manufacturers. We have to do that proactively because there are not requirements, for example, state of operations that are required to report to us.
But if we inspect manufacturing plants, don't we know who they are?
Yes, we do.
Don't we have a list of them?
Yes, we do.
We do?
Yes, we do.
What's the difference between that and the question I asked then?
So we have a list of manufacturers that have been given to us by pharmaceutical companies who manufacture both precursor product and final drugs in China. But there may be 5 or 6 for each of these drugs, and they might be around in different countries.
I see. All right, the gentleman from Massachusetts, Mr. Kennedy, is recognized for his 5 minutes.
Thank you. I want to thank you all for being here. Thank you for being willing to be before this committee. I have some differences with some of you up there on our healthcare policy, but I'm grateful for your presence here, and I wish you all success. So good luck to you, and good luck to us all. First off, a bit of just rapidly, sir, Dr. Redfield, if you can. I got a 2-year-old and a 4-year-old, and a lot of other parents of young children are nervous about this. Can you just give me a real quick question, a real quick answer as to, of parents of young kids, is there anything people should be doing at this point or should be concerned about?
Yeah, I want to echo what the Secretary said. At the current, right now, the risk to the American public is low. And we would argue that they go on with their life. Our containment strategy has been quite successful. But that said, what was said also is that we, in light of what's happened in Korea, Republic of Korea and Italy and Iran and Japan, and we've seen how fast this virus can move, we are encouraging people, again, to just think about being prepared.
Okay. Part of being prepared is trying to make sure that there's as much and as clear communication as to what we are confronting and how government is structured to be ready for this and to meet this challenge. I do think it's, obviously, some of my colleagues have noted that despite calls to strengthen our country's pandemic preparedness, this administration did dismantle the federal government's pandemic response chain of command, including leadership structure at the White House through the National Security Council's Global Health Security Unit. So when you flash forward to this year and the coronavirus starts spreading throughout the world, there have been reports of this task force, and Mr. Secretary, you indicate that you are in fact the head of it. I would ask, just if you can, to the greatest extent possible, communicate what that structure looks like so that people can have some understanding as to what is backing that up. You don't have to do it now, but just as you can, just to get that information out would be helpful to all of us. So moving on a bit, though, to try to make sure that there is not just a structure put in place, but that communication is in fact clear. Mr. Secretary, I would take a bit of an issue with the fact that the message is consistent. I think the message from you all up here, this panel so far, has been pretty consistent. I do have an ABC News story here that I'm going to enter for the record, which quotes the president from saying directly that it is, quote, a problem that's going to go away, end quote. The president is also quoted by saying, quote, the virus we're talking about having to do, a lot of people think it goes away in April with the heat, as the heat comes in. Typically, that will go away in April. We are in great shape, though, end quote. Dr. Fauci, does this go away in April with the heat?
The history of respiratory viruses such as influenza and other coronaviruses tend to diminish and almost disappear as you get into the summer. That's just something that happens every year. We see that with influenza. However, underline however, this is a new virus, so we don't know what this virus is going to do. If it acts like influenza, the heat will actually make it diminish in its impact. But we have no way of knowing how it's going to act.
And I would say that there's different temperature gradients across this country by April. Fair enough?
Correct, and also in different hemispheres, because when we're having cold weather, others are having warm and vice versa.
Thank you. He's also stated that we are, quote, very close to a vaccine, end quote, but Doctor, you just laid out that best case scenario, we're still 12 to 18 months away, roughly, is that right?
Correct.
He had said, congressional staff briefed folks yesterday in a press conference, said, quote, it's not a question of if, but rather a question of when and how many people this country will have severe illness. Almost at the exact same time, the president was saying that, quote, it's going to work out fine, and, quote, a problem that's going to go away. Dr. Redfield, does the CDC agree that this is a problem that is going to go away without intervention?
I think it's important to recognize that from time to time, new pathogens come from animals and get into the human species. Clearly, this is one of those times when we've got a new respiratory pathogen that has come into the human species. And I think it's prudent to assume that this pathogen will be with us for some time to come. And
Dr. Cadlick?
As Tony said, we don't know the cycle of it. We don't know how it's going to, if it's going to be impacted by humidity and heat. But I think we should assume that this virus is going to be a virus that we're going to be challenged with, similar to the other viruses that we have that are respiratory.
Doctor, thank you. I've got 10 seconds left for the rest of the panel. Yes or no? Agree with Dr. Redfield? Mr. Cadlick?
I support Dr. Redfield's view.
Mr. Secretary?
The president's expressing confidence, this team, the public health infrastructure in this country, state and local, that we can deal with this. We will prepare for this. We will work together on this. He's trying to calm a public that we see in China. Panic can be as big of an enemy as virus in these situations. And so there is always that balance.
Mr. Secretary, I don't want to panic over this either. The stock market's crashing. He's trying to stop a stock market. He's not trying, he's outright contradicting everything that you all have just said. Outright contradiction.
I think he's expressing confidence in...
With no medical basis for it. That's what you've just explained to us. Come on, sir.
He's expressing that the American people need to take a breath here, that there's no change to anyone's daily life from this, that the country has a plan. We have pandemic plans. There's a playbook for this, and we're executing against that. But we have to be realistic also and transparent that we will have more cases.
And sir, as head of HHS, do you agree with the president's statements as I quoted? The virus that we were talking about having to do, you know, that it will go away with the heat.
We gotta go. The gentleman's time has expired. Do you want to answer that quickly? No, I didn't think so. You're doing a great job for the president, Mr. Secretary. It's a pleasure to recognize the gentlewoman from Indiana, Ms. Brooks, for her time.
Thank you, Madam Chairwoman, and thank you also very, very much for being here and for your work day in and day out on behalf of not only our country, but on behalf of the world. And I'd like to remind my colleagues that in November of 19, the United States of America was ranked #1 in global health security. A global health security index conducted by Johns Hopkins of 195 countries. We are leading the world. Now, that doesn't mean that we can't always continue to improve, and that's what PAPA, which was passed into law in June, did. It actually took care. It focused on vulnerable populations like children, like the elderly. We added a lot of new things to that. One of the things, though, that I am concerned about is the flexibility of the funding and whether or not we introduced an infectious disease rapid response reserve fund. $85 million was put into that fund. We have $705 million as strategic national stockpile fund. We have all of these. How much flexibility is there, or do we need to give you more authority, Mr. Secretary, very quickly, to have more flexibility to be able to not focus on Congress having to do supplementals all the time? How much more flexibility do you need?
Well, the Infectious Disease Rapid Response Fund has been critical for us. The flexibilities in the Strategic National Stockpile, critical to us. the emergency supplemental, the most flexibility that you could give us there as we deal with the situation as it evolves, we would appreciate that. Also, the challenge with setting up long-term funding mechanisms that are indefinite is they can become slush funds for any other priority as opposed to concrete, real public health emergencies. I think that's always been the challenge.
And if you find that you need more funding for any of these funds, will you come back and ask for more funding?
Absolutely, and I want to emphasize the 2.5 is at least 2.5. It's for 2020 only, and we will come back if we need more, and we will work with Congress if Congress wishes to give more.
Dr. Kadlec, with respect to the strategic national stockpiles, which I believe you oversee in conjunction with the CDC, is that correct?
Yes, ma'am.
What is the status of our strategic national stockpiles?
Well,
Can you quickly say what those are?
Sure, it's a variety of countermeasures that deal with chemical, biological, radionuclear capabilities, as well as for pandemic influenza. We have a supply of personal protective equipment that we have on hand. We have sent out a solicitation to get more, but the answer is we have a whole range of things.
And these are at undisclosed locations throughout the country, are they not?
That's correct.
And at this point, is the strategic national stockpile sufficiently funded?
Ma'am, I think the thing is at this point in time, in light of what the requirements are, we've been given, at least in terms of what is in the supplemental request, another $400 million. That would be a great benefit to help us address any kind of shortfalls for this event.
Last week when I was home, I learned from a local public health official in Indiana that an individual from this county had traveled from China and, interestingly enough, had come through the Chicago airport. And the Chicago airport officials notified this public health official, said this person is coming home to quarantine, which I thought, and she appeared at this individual's home within 24 hours of that person coming through the Chicago airport. I thought that was awesome. It was excellent that that kind of coordination happened. How did that happen, and is that happening all across the country? And this individual is going to cooperate with the local health official, provide their temperatures for a couple of weeks. Is this happening all across the country?
Yes.
And how many do you have? Who at the airports is notifying local health officials?
So what happened when the original travel restrictions were put in for China and Hubei? If you were coming into the United States, American citizen or family member or permanent resident, on Hubei, you were required to go into 14 days of quarantine. That quarantine could have either been institutional or that quarantine could have been in your home working with the health departments. And that's really how we've operationalized. But if you'd been from China, the requirement was that when you came through, you were screened, you were given an education card, provided you had no symptoms, telling you about the risk and what the symptoms are, and the contact information with your local health department. And you, in conjunction with your local health department, were going into what we called voluntary monitoring and isolation. And that woman that you gave the example did exactly as we instructed, and they were instructed as they went through Chicago O'Hare Airport.
And so actually, it was my local public health official that was incredibly impressed that she had received this information. The young man and his family are monitoring. Madam Chairwoman, I'd like to enter into the record. CSIS produced a report in November of 19 about U.S. global health security, making sure we're ending the cycle with a number of recommendations. You and I serve on that commission. Would ask that that be entered into the record.
So ordered.
With that, I yield back.
Gentlewoman yields back. The gentleman from California, Mr. Ruiz, is recognized for 4 minutes. And for those that are left, there's an agreement that it's 4 minutes because the panel is getting nervous about time. So let's honor that. Okay? Thank you.
Thank you for being here today. I want to discuss a very important issue for local agencies, and I know many other members are hearing as well. That's funding and reimbursement for monies that our counties and public health departments have spent upfront to help fight the spread of the coronavirus. I'm a disaster-trained emergency physician, public health expert, and in disaster or epidemic preparedness, rapid reimbursement is a matter of readiness capacity. I think we can all agree that a lot is being asked from the public health infrastructure in our states. They're stepping up, they're coordinating, they're doing the right thing. On January 29, a flight carrying 195 Americans from Wuhan, China was diverted to March Air Reserve Base in Riverside County, the county that my district is in. Riverside County responded efficiently and was effective in monitoring and quarantining all of these passengers for 14 days. Over 40 county officials worked on this project. In addition, the county supplied food, transportation, quarantine supplies, screening, housing, a mobile health clinic, emergency management standby, and support services for ambulance. All told, these efforts are estimated a little over $1.3 million. And while that flight quarantine is over, the broader response continues in Riverside and in communities across the country. So receiving rapid reimbursement is critical to capacity readiness in the future. If you drain resources without replenishing them, you won't have necessary resources to fight this public health crisis, such as bedside diagnostics, personnel, and masks, just to name a few, and also having the resources to create preparedness plans, quarantine plans, et cetera, in the case of rapid transmission of this virus in the future. So I want to ask a question. Dr. Redfield, what are the funds that are available to reimburse state and local officials for their efforts responding to coronavirus?
I'll defer some of this to the Secretary, but I think he said in the supplemental a substantial portion.
Okay, so you're telling me the last time we spoke, you identified somebody in your staff mentioned a few. Now you're saying those funds don't exist. We need to pass the supplemental to reimburse counties. Is that what I'm hearing from you?
So we have the FEP, which funds California at $41 million a year, but the supplemental has requested $757 million
so
for
which
CDC,
funds,
which would have in that the state and local funding.
Okay, are there funds right now that counties can apply for?
No, there are not.
There are no funds.
No additional to the emergency funds that they get each year for these activities.
All right.
That's what the SUP is for.
Well, we're definitely going to work on that, and that's an issue, right? Because we were under the impression that there were, and rapid reimbursement is a matter of readiness capacity. If we don't rapidly reimburse, our local agencies will not be ready to deal with a potential rapid spread of the virus. Dr. Cadlick, Dr. Redfield, yes or no, can we get a commitment from you both here today that you will reimburse these expenses by local municipalities for the costs associated with containing the spread of the coronavirus?
Well, we're clearly going to work to see how to get that done.
Okay, so that's not a commitment. Cadlick?
I think the thing is we're committed to basically work with you to do that.
Okay, well, we need to reimburse because, especially in rural areas where they don't have the resources, they don't have the hospitals, the quarantine spaces, the ability to get the supplies over to those areas, you're putting them in vulnerable situations if you don't respond. Dr. Redfield, since 2008, local and state health departments have lost nearly a quarter of their workforce. Does this affect our nation's ability to mount and sustain a response?
I think it's one of the key core capabilities that we need to continue to improve for our public health ability. That is the data monetization, which you all have helped with last year, the laboratory capacity to build it and keep it fluid, as you see with the current diagnostic test, and the third most important one is the workforce.
Work within a team, be consistent, no discrepancy. Discrepancy breeds anxiety, that brings panic. Okay? All right.
Expired. I wanted to get a commitment so that these agencies don't lose the money that they're losing. You're asking them to promise you even beyond where the cuts are. So I'd be happy if that could happen, but we've got, the Congress has a job to do to restore the money in these agencies. These cuts are really shameful. They really are. And when we have such premier agencies, people at the top that know what they're doing, and they're being cut. And the secretary is telling us, well, we did $1.5 billion, everything is going to be fine. I don't think so. Dr. Bouchon from Indiana.
Yeah, thanks for the 5 minutes. I appreciate it. No, 4 minutes. I'm just kidding.
Minutes.
I mean, in reference to the funding, I just want to, the Congress provides funding for the agencies, and a budget proposal is a budget proposal, no matter which president it comes from. So I'm not too worried that this Congress won't provide the appropriate level of funding, and I understand also that additional funding, if we could quickly bring up the supplemental and pass that, that clearly, in my opinion, would help. Secretary Azar and all the people at this table do their job and get money to everybody. The other thing is, I just want to comment briefly on the criticism of the president and what he has said. if the President of the United States comes out and incites a panic in the United States, it incites a worldwide panic. And I see the role of the President as different than mine or Secretary Azar's or others. And even though, you know, the President says what he says, I do think having a calming effect in a situation like this is appropriate and allow the professionals behind the scenes to do their jobs. I just wanted to say that. And
if I could, I agree entirely. I think the President's role has been actually critical in keeping the country calm in this situation. He's expressed the levels of doubt and uncertainty with his words that we have, but also tried to be reassuring to the American public as we also try to be transparent about what the risks are coming forward. We all have different roles to play here, as you said, and the President's is a very important one, guiding towards balance, maturity, and calm in addressing a public health emergency.
I would agree. I mean, if the President came out and incited a panic, he'd be criticized for that. I guess, you know, we had this unprecedented containment strategy when things were in China. Now that we know we've had problems with person-to-person transmission in Italy and South Korea, and maybe other places, does that change our current containment strategy? And Dr. Redfield, maybe you can address that, or?
Yeah, I would say first that we are maintaining aggressive containment. I want to say that of all the strategies we've used in this multi-layer strategy, the most important one that we have is an astute medical and public health community in the United States. Of those 14 cases originally that were diagnosed, all but one, only one was picked up by the screening. So we're now moving, obviously, to educate the American medical and public health community that it's not just China we have to worry about now. We have to worry about certain places of Italy and Iran and whether it's Republic of Korea. So we're continuing with that, and we're continuing to look at our travel alerts. You know, we've put travel alert to level 3 now for Korea and level 2 now for Italy, Iran, and Japan. So trying to let the American public know this may not be the time to go to those areas.
Okay, great. And again, for you, Secretary Azar, you have anything to add to that? Okay. Again, Dr. Redfield, as far as the testing goes, the CDC, 12 other public health laboratories have the testing, but I guess they had some difficulty with the third reagent in the test. And can you further explain the problems with the test, and have those problems been resolved?
So first, the test really measured 3 different, let's just say 3 different nucleic acid pieces. And one of them had a control, the third one had a control, and in that control there was low-level contamination. There was never any question about whether the test could tell positive or negative. It just had a group of individuals that we had to say we didn't know.
Okay.
And those samples, again, were at CDC. CDC's continued. We've doubled. I found out we're at 350 to 500 samples a day when the question was asked earlier that we're running right now.
So the problem's been resolved, basically.
The problem's being resolved. We work with the FDA, and we have a fix that's supposed to be operationalized this week.
One other quick thing. Have you guys conducted disease modeling for a potential COVID-19 outbreak in the U.S.?
We do have modeling groups. It's a global modeling group that's looking at a variety of different models, and that's in process. As Tony said earlier, there's still a number of things we don't quite know about this virus to make those models available for prime time, but we are working at
working on it. Okay, thank you very much. I yield back.
The gentleman yields back. I think that concludes the questions that we have for you today. Thank you to each one of you. Mr. Secretary, you've been here for many hours, and you know, throw a punch, take a punch, right? But we're all here for our fellow Americans, and I think if there's anything that's come out of this today, we want facts. We want to bring the temperature down. We want to bring the fear factor down, and anything and everything that you can do in order to achieve that as we move on with Dr. Fauci's work, with larger distribution of the diagnostics through the CDC in partnership with what we have across our country is going to go a long way. So thank you to each one of you. I'm not going to adjourn. You can get up and leave while I read a very long record of items that need to be placed into
Thank you, Chairwoman.
Into the record. Thank you. God bless you and your work on behalf of the American people. Thank you. All right, I'm going to request, I have a unanimous consent request to enter the following documents into the record. A June 28th letter from 4 House committees to HHS and CMS regarding the case Texas versus the United States. A December 2018 letter from 4 House committees to HHS and CMS regarding the case Texas versus the United States. An April 2019 letter from 5 House committees to HHS and CMS regarding the case Texas versus the United States. A February 2020 letter from HHS in response to the April 2019 joint letter from 5 House committees regarding the case Texas versus the United States. If the committee actually is still in order. I wanted the witnesses to be able to leave, but if anyone wants to gab, take it into the side room so that I can read these into the record, please. February 2020 letter from HHS in response to the April 2019 joint letter from 5 House committees regarding the case Texas versus the United States. An October 2019 Washington Post article entitled "Trump Campaign Urges White House to Soften Proposed Flavored Vape Ban," unquote. An October 2019 bicameral letter to HHS from 2 congressional committees regarding the increased number of uninsured children in the United States. A June 2019 letter from the Energy and Commerce Committee examining HHS's administration of the Medicaid program. A statement from Johnson & Johnson regarding the company's response to the coronavirus outbreak. A statement from the American Society for Microbiology regarding the coronavirus outbreak. A February 2020 article from BioCentury entitled, quote, "Biopharma Industry Academics Push Back Against Demands for Price Controls on COVID-19 Countermeasures," unquote. A January 2020 Wall Street Journal opinion piece entitled, quote, "Pharma to the Rescue," unquote. Are there any objections? Without objection, so ordered, and the subcommittee will now adjourn. Thank you, everyone.